ahead and get started, so if you all could take your seats. All right, welcome. Thank you so much for joining us here this morning. I'm Amy Latham. I'm the Portfolio Director for Healthcare and Health Coverage at the Colorado Health Foundation. It is my privilege and honor to welcome you all to this morning's Symposium Unplugged event, Colorado's Journey to Integrated Care. We've had a fantastic response to this event. We had nearly 200 people register to be here with us in person this morning. We have another 100 plus people who are joining us online this morning via a live stream of the event. So welcome to all of you. The Colorado Health Foundation's vision is that together we will make Colorado the healthiest state in the nation. And that word together is very important and it's very meaningful to us. As I look around the room today, I see many individuals and organizations who are playing a really active and essential role in helping us make progress on that vision. Thank you for the work you do, and we're honored to be your partners in that work. Our healthcare outcome area goal is that all Coloradans achieve health with support from a network of primary care, with a network of primary care and community services. And for us, primary care is integrated care. We mean integrated behavioral, physical, and oral health services when we use that term. As part of that work, we've had the opportunity to invest in practice transformation efforts and integrated care delivery because we know that investing in that work results in better outcomes for the individuals being served and positive outcomes for the system as a whole. Colorado's been an innovator in this area. Many of you in the room have spent years building models and testing payment models, testing delivery models, building partnerships, and really setting the pace for the rest of the country in this work. So our Symposium Unplugged series is really designed to complement our annual Colorado Health Symposium that's held up in Keystone in the summer every year. I think many of you have had the chance to join us up there. If you haven't, I hope you will consider doing so at a future symposium. In these events, we focus on a single topic. We go deep on a specific topic in a smaller, slightly more intimate setting than up in Keystone, slightly less dancing, although I'm not sure what Michael has planned, so we may dance this morning, I'm just not sure. We also really want to focus on best practices and solutions, what's happening on the ground, and you'll see that in today's event. You'll see that we also want to have an event that really is focused on collaboration and learning and engagement. Today's Symposium Unplugged, Colorado's Journey to Integrated Care is very timely and very relevant, not given just Colorado's progress in this area to date, but also the opportunities that lie ahead of us, particularly the State Innovation Model Grant, which Colorado was recently awarded. So we're really excited about today's conversation. Our partners at Advancing Care Together have been incredibly helpful in planning today's event. I want to recognize Dr. Larry Green, Maribel Cifuentes, Linda Niebauer for their work in planning this morning's event, and thank the entire ACT team for sharing your work with us this morning. So I'm just the lucky person who gets to stand up here and welcome you all. There's a huge team of folks who've worked really hard to make sure that not only is today's event flawlessly executed, that it's meaningful for each and every one of us in the room today. I just want to call out a few names. Taryn Fort, our Director of Communications. I'm going to point randomly to places in the room because I don't know where all these people are, so just play along with me here. Kendall Morrell in the back of the room, our Communications Manager. Tanya Weinberg, Senior Program Officer at the Colorado Health Foundation. There she is. Let's see here, Beth Clemens, who helped plan this morning's event, Michael Booth, who I will introduce in just a moment, and really the entire communications department at the Colorado Health Foundation. Thanks to you all for making this event possible this morning. I also want to recognize Ron Porter, our interim CEO. Kelly Duncan, I don't know if Kelly's in the room this morning, our outgoing VP of Philanthropy at the Colorado Health Foundation, and then Dr. Jerry Buckley, board member at the Colorado Health Foundation in the back of the room. Thank you for your leadership and support for this event. So on a regular basis, I am lucky enough to get to hear firsthand stories from folks around the state who do this work on a daily basis, who provide integrated care to their clients. They share their stories with me, and it really confirms for me the value of this model of healthcare delivery. But every now and then I hear one of those stories that really stops me in my tracks, and I get a really powerful reminder as a mother, as a wife, as a daughter, as a friend, as a patient in the healthcare delivery system about the life-altering potential of this work. Those stories are so powerful, and I'm so excited to be here this morning to get to hear those stories and be reminded again of the importance of the work that you all do. I know you all are excited as well, so without further ado, I'm going to turn it over to Michael Booth. Michael is the MC for this morning's event. Michael is the editor-in-chief of our quarterly health policy journal, Health Elevations. Michael?
Thanks. Thanks, Amy, and thanks to all of you for giving up your time and spending time with us here today for this very important event. And we want to let you know that the foundation and its partners will continue to work on integrated care and write about them and tell stories about them and share information. You pass on your way in the next cover, the May upcoming issue of Health Elevations, which is completely dedicated to talking about integrated care in Colorado, the progress we've made so far, this fairly unique moment we have of creating a tipping point with the SIM grant coming up to really spread integrated care into as many practices as possible around the state. And so to do that, we need more information. We need to share the information, share the stories about what's worked, what hasn't worked so far. Our May issue talks a lot about that, talks about the payment reform that many people say needs to go hand in hand with integrated care to make it all work. And so we hope that you will pick up a subscription card for Health Elevations or hand me a business card. We'll get you on the subscription list. All our content is available online as well and archived, and so that will be available in May. We hope you will continue in that conversation with us and let us know what you think of the content in Health Elevations. In doing the reporting on Health Elevations for May, we were lucky enough to go around the state and meet some amazing people who are doing integration at practices. One of those practices, Southeast Health Group in La Junta, and I know they have some representation here today on the sign-up sheet, were nice enough to host us and welcome us and talk to us about what they've been doing. And they told us a pretty amazing story about how it's worked for them. Southeast Health Group, La Junta, small town, Arkansas Valley, long-time mental health and behavioral health and substance abuse provider for the Arkansas Valley, has been, through ACT and through its own efforts, adding primary care within the mental health part of the practice and behavioral health part of the practice. And they came across a patient who had been to other practices, other primary care practices in Southeast Colorado. And this patient was not an easy patient. She rambled quite a bit in her conversation about her case and her past. She exhibited some sorts of behaviors that might lead people to think she had some issues with schizophrenia. It was very hard to figure out, sort out her claims of pain, physical pain, from the other things that she was talking about. And other practices had kind of given up on her and actually sort of written her off as a non-compliant patient. Well, she came to Southeast Health Group and met with Callie Mae Mendoza-Warner, who's so great she needs 4 names instead of just 2. And because of the way Southeast sets up its time, they have Callie Mae, the most appointments they give her in a day is 13 and a half. And as many of you know, many practices in primary care are doing 20, 25 appointments a day. That 13 and a half appointments gives her the time to sit down and talk and try to sort out what's really going on with patients. And when she sat down with this patient, she heard her story and listened, and then also was able to just walk across the hall and do a warm handoff or sit in on the conversation with a mental health provider and help sort out these issues, and then recommend that she get some physical testing and some imaging. Well, it turns out this woman's severe pain was because she had a large mass in her abdomen that had developed into stage 4 cancer. And it doesn't end there with Southeast Healthcare and the other integrated care that is going on in this room. They not only diagnosed her and helped her on her way with what was going to be happening next, they actually arranged for driving for her for every day, 5 days a week, for the next 8 weeks to go to Pueblo. So imagine this patient who has these many needs, how scary it would be to go over to Pueblo on her own, and Southeast made sure that that was taken care of and that she had somebody with her to do that. And as Callie Mae put it, she would have died if they had just left her with a diagnosis that she had had before, the lack of diagnosis she had had before. Literally would have died, and that was a life-saving situation. And that's the kind of thing we're talking about in integrated care and the kind of stories you'll be hearing more about today. So we applaud the work that they're doing, and we'll be hearing more about that from them and from other practices. As we go through this today, I'll tell you a little bit about how the morning's going to work. Dr. Larry Green's going to talk first about the history of ACT and where ACT is going in the future. And then let's look at it in terms of the rest of the morning. Think of it as a Google view of integrated care in Colorado. The first group is going to be sort of a street view with a panel that we're going to be having that comes from actual providers, actual ACT practices in Colorado. and some of their patients who have been generous enough to volunteer their time and come here and tell their stories for us about how they got into integrated care and how it's worked out for them. After that, we're going to pull back for a little bit more of a sort of a state view with Deborah Cohen, who has been the longtime evaluator of ACT and has a view of all 11 ACT practices, how they're knitted together, what's worked for them as a group, what hasn't worked for them, and the principles that they can share with the rest of Colorado and the rest of the country. Then we're going to pull back one more time to sort of a Google World view with Drs. Beardsley and Dr. England from Boston, who will be talking about their specialty of child psychiatry and integrated care as it seen from family practice level and early prevention. And what they've seen in Colorado, Dr. England is the chair of the steering committee for ACT, and so she's intimately familiar with what's been going on here. And they will both have a conversation after Dr. Beardsley talks with each other and with all of you about what they've observed. So as we're going through all this, we know that none of you are timid in your practices or in your nonprofits. We want you to raise your hand. We have microphones. It's not that big a room. If you don't get a microphone, just raise your hand and we'll point to you and you can shout out your question. If you'd rather have somebody else ask a question, please use an index card on your table and write out a question, and we'll get them to a staff member. We'll come and collect them, and Tanya's going to help us sort out those questions and make sure we get them to the right people on stage. So please participate. We don't want this to be me talking. We don't want this to be only the panelists talking. We want all of you to be talking with them, making observations, asking them questions. So please do that. And a little bit of housekeeping along the way. We do have the hashtag down at the bottom. I know none of you will be looking at your phones this entire time, but if you do, use it to tweet with that hashtag about what we're doing here today and what your own observations on that. Wi-Fi, as I tell my daughters to not use all the data, there is Wi-Fi in the room and you can use it. It's on the information about that is on the back of the agenda. So you can link on that way. And turn off the sound on your cell phones. We want you to tweet, but we don't want you to be ringing while this is going on. So please do that and help us out. So without further ado, let's have Dr. Larry Green come up on stage. Dr. Green is a longtime family practitioner and leader of ACT, program director, and has worked on many, come on up, Dr. Green, he's worked on many federal and local programs trying to integrate care and further it. And his idea sometimes of integrated care is trying to get everybody together in his pickup truck at the same time. But he's been the leader of ACT for a long time and will tell us about the history and where you're going.
Thank you, Michael. I want to add my welcome. I mean, it's just like the Denver Post says, it is a privilege to live in Colorado on mornings like this. I mean, it's just gorgeous. I had a hard time getting in here. But I so appreciate all of your coming and being here. I want to start off thanking the Colorado Health Foundation, its board of directors, especially Tim Cortez, Suzanne Brennan, Erica Snow, and wonderful, wonderful Tanya Weinberg, who really made all this possible. It's important to me to convey to you the size, scope, and nature of the courage that the foundation showed in supporting a project like ACT. They did this before integrating mental health and primary care became as fashionable as it is becoming. It's an act of courage. It's an act of leadership. We're very fortunate in Colorado to have a foundation that can do that and will do that and did do that. So before I do the rest of my assignment, let's start with the story. We're going to meet Patrick. And just watch the screen here.
Hi, I'm Patrick. This is my health story. I had the good fortune of 52 years, as I'm now 62, of what I'd consider to be perfect health. I was an athlete, always an athlete. I don't remember an injury. I didn't get sick much. And I had sold my business and I was prepared to become a competitive tennis player at age 52. And in a moment in time on a tennis court, I ruptured a disc into my spinal cord and partially paralyzed the lower half of my body. And then I become divorced. I don't really have a career anymore because I sold my company. I don't have a body anymore to speak of. And I'm broken. And I then go away for 4 full years. And so I took my isolation into alcohol and began to use it as my coach, my friend, basically, as any alcoholic will tell you. So as my life unraveled and I became to realize how broken I was, I didn't expect that my doctor would be the person that walked in that I would open up to and break my isolation. As an MD, he's a straight line MD, and all of a sudden it's different. And after we do all of my vitals and we do this, he comes in and he sits down with a clipboard or with his computer, and he says, okay, where are we going next? And we talk for 15 minutes about where I'm going next. And now after we go through my checkup, I see that the real appointment starts. Where are you? What have you done? Where's your training? Are you wearing? And he starts to go through a checklist that is well-oriented, not sick-oriented. 3 years into becoming empowered in my own health story and my own wellness, I was beginning to reach limits, and I started to lose some of the meaning of my own recovery program. I had stopped again. And when I sat in front of Glenn, and now my trust is, of these years of doing this, my trust is high, and I say, I'm afraid I can't go further. Where do I find the courage to go further? Here again, that moment when Glenn, instead of saying, no, you're doing great, he could have said that, and that would have been an answer that I would have believed. But he didn't. He said, okay, next, if you want the courage, I believe it lies in your behavior. So let's try some behavioral counseling. So working with a psychologist, being recommended by my doctor, so we were on point with what I needed to learn in order to move these programs forward. And fortunately, because I had a driving mission at that moment, the coaching was very direct, and it immediately broke open the underlying issues of why I had plateaued. And almost within a month of regular sessions, I felt I could see up again, and I started to move up. I've gone from a single bike path where I would fall off every 3 steps to now I feel like I'm navigating a 6-lane highway, and I have the group as my bumper guards. But I've got a 6-lane highway. It's up to me. I'm driving. I'm going. And they're there to make sure now that I don't fall off the outsides.
So there's only one Patrick, there's only one Jennifer, but there are hundreds of thousands of people in Colorado today that are in this type of situation. And that's what we're here to talk about. We will soon meet Patrick. He's here, and he'll be up here on the stage in just a moment. My next assignment is to sort of reprise the situation, put this into context. Well, this idea of so-called physical health and this idea of so-called mental health, it's a fallacy. We have known definitively since 1994 that that division is a mistake and cannot really exist in real life. That has not kept us in the United States and across most of the world of spending more than a century of breaking things into smaller and smaller parts when it comes to healthcare. Not balancing that subspecialization with an integrated focus, a dose of generalism, and bringing that into proper balance. It's out of balance. It's out of whack. It doesn't work really too well right now. We do so much in so many pieces. What we mean by integration in ACT is the pulling together of things, what that may apparently appear to be separate parts, into a coherent whole that is meaningful. And in this situation, it's meaningful first and foremost to the person, the client, the patient, I hate the word consumer, but I guess I have to use it every now and then. But also from the point of view of the payer, and also from the point of view of the clinicians and the staffs that want to help these people have better lives. That's what we mean by integration. Integration is an antidote to this fragmentation that is entrenched. It's been here a long time, and it must be overcome. So there are lots of challenges to advancing integration, specifically the integration of primary care and behavioral health. Now, by behavioral health in ACT, I want to be clear about this, we mean mental health, mental diseases, unhealthy behaviors, substance use, and emotional problems. They all come in a package in things called human beings. They always are wrapped together. And when I say the word behavioral health, please know that that's what we mean in ACT and will mean throughout the morning. The barriers here include history, precedents, changes in science, changes in technology, changes and the lack of changes in the workforce, obsolete policy, balkanization of clinical tribes, balkanization of the public's thinking about these issues, and undercapitalization of frontline services all across Colorado and all our communities. Other than that, it's pretty straightforward. Now, and as I say, meanwhile, think about the prevalence of this. In a typical year, in a state the size of Colorado, 5.5 million people, you can expect close to 1 million of us in this state to actually experience a substantial mental or emotional behavioral problem. That is a big deal. Okay, now a brief explanation of ACT and its approach. First of all, it's a journey, and it's not over by far. But the journey toward integration that became ACT, Advancing Care Together, commenced in earnest on May 21, 2009. I'm sure you want to remember that date. May 21, 2009, Tim Cortez from the Colorado Health Foundation emailed us and said, "Congratulations, our board of directors has approved a planning grant." And that planning year is what produced ACT and what we're talking about here today and reporting from today. Now, the purpose of ACT was to learn how to actually change practice. Now, that may seem really straightforward and obvious to you, but this is extremely unusual. Most of the time, this type of work is done somewhere in a laboratory or in a small group of practices, and once they do that project, then it's sort of done and it gets written up. That wasn't our intention, and it's still not our intention. We aim to change practices all across Colorado. And ACT wanted to learn how to do that. So we wanted to do this in diverse localities and under diverse business arrangements that were representative of the mix of practices that exist in Colorado. So we work with community mental health centers and community health centers. Large practices, big practices, rural practices, urban practices. The idea, not quite a Noah's Ark, because there's only one of every kind, but dispersion, diversity in the portfolio who did the work. Now, ACT also sort of adopted an attitude, a little bit of an edgy attitude, perhaps, but it comes down to this. Enough already of talking about doing this. We've been talking about it for decades. Let's see if we can do it. And so it was an action-oriented ACT. ACT was about action and actually moving into real-world situations and trying to do it. Relatively radical idea, and when I thank the foundation for their courage, I think it took a lot of courage to place a bet on this approach. So instead of telling practices what to do, Here, the research says that you should do A and B. Go forth and do that. By the way, we're going to be looking over your shoulder and tell you whether you got it done or not. That's not what we did. We started off asking them, what do you think you could do under your circumstances in your community to do a better job of integrating primary care and behavioral health to better care for the people with mental and emotional problems? Well, we got a great response. Eventually, 11 sites were selected that capture this diversity across the landscape, the mix of ideas. They're shown on this map, if we could see this next slide. Then, instead of getting a big check and a wish for good luck, they got a smallest check to cover their cost of participating in the program and an invitation to work very, very hard. Overseen and guided by an ACT steering committee that was comprised of both Colorado and national leaders, a very good idea, by the way. It proceeded, and ACT made available some on-site support for practice redesign work using approaches that were known to help practices change. We emphasized the evaluation of each practice as its own case, using multiple methods in real time to observe, learn, compare, and share how this could be done. What worked, what didn't work. We established a learning community where frank and candid discussions occurred, cracking through some of the barriers. We learned to trust one another. We learned to take risks together. We learned from one another. We planned 4 face-to-face collaborative meetings. The practices asked for more, and there were more. 11 practices started, 11 practices ended, but they didn't end where they started. And some of them were in totally different form by the end of it than they were when they began. So now the active phase of ACT has concluded, and we're actively disseminating what happened, what was learned, and we're doing it not just someplace, but in Colorado, a state that is simply brimming with the opportunity to redesign the way we actually provide and pay for health care, specifically the SIM led by Vatsala Pathy, but also the additional work like Perry Dickinson is doing in developing an extension service to help practices change. So now I'm going to conclude, but it is with great pleasure that I want to introduce to you to some of the ACT family. It's a band of sisters and brothers who created this journey toward integrated care. So if you're an innovator, if you worked in one of the practices at one of the 11 innovations, would you just stand? These ladies and gentlemen personify the word courage. What they did was nothing short of courageous. I also want to ask our steering committee, if you were on our steering committee, would you please stand up? I'd also like to ask our anyone that would help with the practice assistants to stand. All you guys just keep standing up here for a second. We have our evaluation team underrepresented, but we have Debbie. So Debbie, you need to stand. I mean, talk about an amazing evaluator. And so anyway, this is the crowd that is presenting what we want to share with you today, and we're hoping will stimulate a conversation that will continue the journey toward integrated care. And I want to call out what Dr. Beardsley will be talking with us about. There is a science base, mostly lying fallow, mostly unimplemented, about how to move upstream and prevent mental and emotional behavioral problems and promote well-being. And that's going to get in the conversation today. Looking forward to where the journey can go next. So thank you all for coming very much. Back to you, Michael. Can we go back one slide there? That's the crowd at one of the learning collaboratives. So we joke about Margie Harbeck is lying in front. I'll leave interpreting that to you.
If the panelists could come up while I'm talking, and we'll introduce you as we're going along. We promised you the Google Street View of what it looks like with practice integration in Colorado, and so that's what we're going to do now. You guys just sit wherever's comfortable, and we'll use the microphones, and we'll pass them back and forth. And again, this is a chance for you in the audience to be ready to grab a microphone and ask a question, or just stand up and raise your hand and let us know when you're ready to talk. So our panelists today that we have with us are a couple of the stars of the video you already saw. Dr. Glenn Kotz from Mid-Valley Family Practice in Basalt. Patrick, who you saw talking with Dr. Kotz in the video and in still pictures, and they'll tell some of their stories of working together. We have Carla Payaras from Salud, who has been working on integration for pregnant women and their patients, and we'll hear more about that. Minnie Cloden from Jefferson Center for Mental Health. We'll talk about integrating in the Denver metro suburbs and mountain suburbs. Jennifer Sharp is a patient of Westminster Medical Clinic with Dr. Scott Hammond, and they're here today to talk a little bit about share their stories of integration as well. So let's start with Glenn and Patrick, because we already heard a little bit from you guys in the video. Glenn, why don't you talk a little bit about, Patrick told some pretty amazing stories about what you guys were able to do for him in some different crisis periods of his life, both physical and mental health issues that he was going through. Tell us the story of what your practice looks like and how you created the time to talk so much with Patrick and give him the time that he needed to take care of his case.
Welcome, everybody. As everybody in ACT knows, sometimes I'll ramble a little bit, so bear with me, I'm sorry. Kind of our journey in our practice started during my residency when we were lucky enough many years ago to have an integrated residency program introducing me to behavioral health in primary care. And I was lucky enough to take some of that when I moved into a solo practice in a small town in western Colorado. And I started by trying to implement behavioral change in all of our patients. And it didn't take long to realize I was not going to go anywhere. To use the simple example was that I would always ask everybody in their physical exam, what was their diet? What did they eat? And I would start to write it down in our then paper charts. Yes, I'm before the computer age. And I'd write down breakfast, lunch, and dinner. And I would tell the diabetic, hypertensive, that maybe donuts wasn't the best choice for breakfast, and maybe bread, mayonnaise, meat, no vegetables, soda, cookie, chips was not the best idea for lunch, etc. And every year they'd come back, and for a couple years I'd ask them the same question, so what's your diet look like? And I'd write it down. And then I realized, no matter what I'm telling them, nothing's changing. And I just started looking back at last year's diet and asked them what they were eating, and it was the exact same thing. Donut, sandwich, chips, whatever it may be. Absolutely nothing was changing. During this time in our development as our practice, I was incredibly lucky enough to stumble upon a staff that was just amazing. And they would start asking questions more than I would. What's going on? Where are we going? We're not really getting where we want with our patients. What do we need to do differently? And one day, one of my staff, who much smarter than me, said, you know, we are lucky enough to spend 30 minutes every 3 months with these patients that have chronic disease. How many minutes do they have in between those 3 months? What does that mean? Do we really know what's going on with these people? And of course the answer was not really. We started asking many, many questions. What is health? What does health mean to people? How do we obtain health? How do we intervene? And in about 3 months after that, luckily, magically, there was an email asking for people to sign up for Advancing Care Together. And we had no idea what that really was, but we threw our hat in, and magically we were asked to join an amazing group of people. And the Colorado Health Foundation putting it together, the steering committee, the faculty of the university, just amazing. And the environment that they created, I think Larry made a comment that they created a safe environment for us to discuss things, is an understatement. to have behavioral health people and medically oriented people in the same room and discuss things for 3 years, and to be able to discuss them honestly was beyond what most people can really imagine. The arguments that we had, the fights that we had, the learning that went on was absolutely magical. And as I told them when our 3 years together ended, this can't end. We're not done. We have so much more work to do about learning what integration is, about learning how to help individuals in their care.
So Dr. Kotz, before you started working with ACT and you had a patient that needed more behavioral help than maybe you were getting in a regular primary care visit, what did you do with that patient before?
So one of the things that we see in behavioral health is that if in primary care, if we know that are lucky enough to pick up something and refer them out, we were quoted, 30% go, 70% don't. I think it's a much higher number in my practice. Most of the people would not go to their referred behavioral health providers. So in our journey to bring in behavioral health, Corey Smith, who is our psychologist, created an amazing environment in our practice for our patients. Patients started coming in and saying, you know, I have a problem. They wouldn't tell us that before. Our behavioral health people in our practice created an environment where they taught us how to speak to patients. They just didn't see the patients. They taught us how to interact with patients. The patients would come in and go, you know, I have a problem that they would never tell us before. And I realized very quickly that as a doctor, I communicate with patients intellectually. The staff and the behavioral health people communicate with the patients at their heart level. So that whatever I would say from an intellectual standpoint would stop here. What the staff and the behavioral health providers would talk about would take care of the rest of the body. And change started happening.
And how did you bring them in? Did you already have behavioral health people on staff? Did you bring in outsiders for certain hours? Tell us how you did that actual integration part.
So initially with ACT, we tried to partner with an organization, a behavioral health organization, and we actually hired a behavioral health person to work roughly 2 days a week through that organization, and unfortunately, that just didn't matriculate. So eventually we hired our own psychologist full-time, and that was a dramatic change in doing that. Having the ability of Corey to be there, interacting with patients, interacting with staff, we talk about touch factor, and our touch factor is very, very high, not just with the staff, but with patients. Patients love it. And I wanted to tell one patient story, and I promised myself that I would do it from yesterday, whatever was yesterday. And the importance of that is I knew I would have yesterday's patient for today, because it happens every day. So yesterday's patient was a wonderful 51-year-old gentleman who fell off of a forklift 20 feet in the air, fractured his skull, had bleeding in his brain. They had to remove part of his skull because of the swelling. And he's an amazing person. And shockingly, he has recovered essentially everything physically. And I don't remember the exact day. I'm looking at Corey a little bit, a month ago, 6 weeks ago. He's ready to go back to work. And I said to him, you know, are you ready to get back up on something, whatever it may be? And he looked at me and said, you know, I'm really scared to go back to work. I'm ready, but I'm too scared. Well, obviously, Corey saw him a few times. Yesterday, he comes in and says, you know, I want to thank you for having me see Corey. I'm ready to go back to work. Can I go tomorrow? And that was yesterday. I can pick any day. It doesn't make any difference. So having Corey there having behavioral health in our practice has not only changed one individual, Patrick's very, very special, it changes every day our patients in our office. It changes alcohol, tobacco, all the different things that Dr. Green had mentioned earlier are changed on a daily basis with many patients. Queries, contacts are throughout the day. And I do want you to come back to me at the end and ask me what I do next.
Oh, of course.
So
Absolutely.
I don't want to.
Yeah. No, one of the things
dominate
I want you to save during the conversation when you talk about how you found the right psychologist who would fit into the practice, because there's been, I know with active evaluations, there are always questions about, you got to find the right people. It's not just anybody who can integrate either way, whether a mid-level practitioner who can integrate into behavioral health or vice versa. So do want to hear more about that. But need you to share the mic with Patrick for a minute about his experience. Patrick, did it look different to you when you first started seeing the practice, in terms of when they would say to you, well, it sounds like you also need to talk to not just a medical doctor, but a different kind of counselor. Tell us how that worked for you, and were you ready for it?
Hi, I'm Patrick. Enough about me. The right resource at the right time. Where I left to my own devices, we might have identified a moment in time where I needed something else, and then as Glenn would have said, well, here's some people, why don't you go do that? And when you're in a place where you're scared, the last thing in the world you want to do is face that. So the excuses, as you might imagine, can pile up. And so when the person that I'm seeing is 12 steps away and the appointment is made, it's hard to be frightened enough not to walk 12 steps. So that's what's changed. Amy is in the other room. We have set an appointment with you. I believe it'd be good for you to do that. Would you go over there? No. I've got to wash my hair. Yes, of course. And at that moment in time, the presenting problem, to use the language, the vernacular, I was 40 more pounds overweight. I had lost 20 pounds on pure will, but I had another 40 to go, and I was stuck. So I was at health risk. I was on my way out. I was ready to be a happy Buddha and just drink and meditate the rest of my life. And that changed everything. And so Amy sat down, and we worked very pointedly, as I said in the story, on the first presenting problem: what's up with food? Mm-hmm. I said, why? Obviously, that opened up the door for a lot of conversation.
Did you have to overcome any barriers in your own head of, wait a minute, now they're not just telling me I have a medical problem now, they're telling me I have some other issues, and I don't know if I'm ready to think about those or act on those?
Fortunately, no. I think that's what made for a good pairing. You know, Glenn and I had worked together for 20 years and had an honest relationship over the years. So at that moment in time, that wasn't an issue. I was stuck. The issue was Glenn knew me well enough to say, I would like you to, I recommend you do this, and I recommend you do it now. And our trust had, at that point, had grown enough that I said, show me the way. So that wasn't an issue at that moment, because again, we had a deep degree of trust at that moment. He'd gotten me through the first 2 or 3 years of some pretty serious extreme makeovers. And so so that wasn't an issue at that moment. I didn't have it would sound like the best idea I ever heard, as a matter of fact, but the surprising point was, where did the idea come from? If I had to go source the idea and source the solution, like 70-30, I would have been probably one of the 70 that didn't do it, or waited 3 more months, or gained another 5 pounds. Meanwhile, then I become another extreme makeover.
So the fact that the other help was physically within the practice was an important factor for you. Kept you from running out the door, kept you from putting off the appointment, made you comfortable with it.
Critical would be the word.
Okay.
I mean, I can just go right over there as part, and also as part of my medical treatment, it was part of my insurance plan in that way. I didn't, it all shakes itself out in terms of my share of the cost versus, health insurance share. But the point was, there was nothing to do. I made an appointment for a week later through the medical practice. I showed up in the medical practice. I think the environment in this case helped the situation, because I wasn't going to a therapist's office. I wasn't going into a therapeutic situation. I was in a medical practice receiving behavioral care. So it did, I would say in that way, it did break down some of the resistance I might have in my mind. What do I mean? What do you mean I need therapy? No, you don't need therapy. You just need a little behavioral health coaching. Great. I was afraid I was going to need therapy. So yes, the context did change everything. And the recommendation, the respect, you all have an enormous power with and around us as patients. And so to a lot of extent, you must realize as caregivers, what you say is what we want to do. So coming from Glenn, that was what changed it. And the setting changed it also.
I want to come back to you guys in a little bit, but I wanted to also include another kind of practice. So Mindy, coming from Jefferson Center, where you're were primarily a behavioral health practice, but I want you to tell us more about that. Give us kind of,
one last thing, I apologize, this will be very brief. I wanted to thank ACT, I want to thank Glenn. Not a big deal to walk a mile any longer, but I was just thinking 6 years ago, walking a mile from my hotel to here would have been unthinkable. So I want to thank you all, and Glenn especially, for just being able to have a story to tell. Thank you.
So Mindy, as part of your integration, I assume that you've been bringing in physical practitioners or somehow integrating them. So give us a picture of what Jefferson Center does and different locations that you have.
Sure. So I'm Mindy Clouden. I'm the director of the Office of Healthcare Transformation. There's nothing to turn.
They have to turn it on.
Thanks.
Hello.
Appreciate that.
We can play jump rope up here. Good morning. I'm Mindy Clouden. I'm the director of the Office of Healthcare Transformation, which is part of Jefferson Center for Mental Health. And we're the community mental health center that serves 3 counties to the west of Denver, Jefferson, Gilpin, and Clear Creek. And we have been considered by a lot of folks kind of an early adopter of integrated care as we started our journey in around 1995, integrating in school-based health centers, and then throughout the 90s and 2000s, providing behavioral health services in primary care settings. And when the ACT intervention was coming around, we were really taking a good hard look at our own patients and the needs of our own patients. And there's been a growing awareness, kind of the number that everyone seems to know now is that people with serious mental illness die 25 years younger than their counterparts, largely due to preventable conditions. It's even more dramatic for folks that have co-occurring substance abuse disorders. The average age of death for co-occurring substance abuse and mental illness and other comorbid chronic health conditions is 45. So we were really taking a good hard look at our own patients and what do we need to do to ensure the whole person is being treated. And we have a number of patients, we had more than 2,000 patients that had Medicaid, so had a payer, but did not have a primary care provider. Many of them had not gone to see primary care in a number of years. And so we started conversations with Metro Community Provider Network, which is one of our long-standing integration partners, about bringing primary care into the mental health setting. And really wanted to kind of acknowledge that there are a number of patients that see us as their healthcare home. And for many different reasons, don't want to go anywhere else or can't go anywhere else for their care. We also thought we really need to enhance our services to be able to better serve the substance abuse issues, treat the substance abuse issues that many of our patients had. So we used the ACT intervention to bring in Arapahoe House to provide substance use screening and brief treatment. I want to also call out that we didn't think that we would be able to make this effort successful without care coordination. And care coordination is a very difficult thing to pay for in the community mental health center setting. So I want to acknowledge Rose Community Foundation because they also helped us with this effort. It really shows that it takes a village. And so weaving together all of these different funding sources and braiding these different funding sources, we were able to create clinics in 3 of our community mental health center based settings and start providing integrated primary care and substance abuse services.
So tell us a little bit about how it might look from the patient's perspective. I'm perhaps a Medicaid patient coming in for substance abuse treatment or just therapy, but I also have physical needs, either related to substance abuse or in general. How do you link them up? Where is the provider located? Who does the case management?
Right. So we have, as part of our intake process, identifying if a patient has a primary care provider, getting permission to have a release of information signed right away. And as patients were identified as not having a primary care provider, if they were appropriate for these services, we would refer them to the care coordinator, who would then outreach them and invite them to come and take part of the clinic. I think one of the key things for us was that we wanted to make sure that folks felt comfortable and were able to kind of talk through with the care coordinator any barriers that they may have to accessing primary care. A lot of folks had fears and concerns. They may have been mistreated in other settings, or they may have just not felt kind of ready to deal with their own physical health issues. And so the care coordinator played a really critical role in helping to mitigate any of those barriers.
Do you also work on some of the social aspects? It's hard for me to drive from one place to another. I need a ride. Picking up prescription can be difficult. Tell us a little bit about that.
Sure, absolutely. I mean, what we tried to do was to, as much as possible, piggyback appointments. So a lot of the clients that we were serving were, they may be coming in monthly for therapy visits or coming in every few months to see their prescriber, their psychiatric prescriber, and we would try to make it, as, to the extent that it was possible, make their visits with the primary care provider coincide with one of those visits.
Okay, great, thanks. Let's go to Carla next. Carla Payas is from Salud Family Health. Carla, tell us a little bit about your part of the state and the group that you're serving, and you have decided to, or early on, concentrated on pregnant mothers. So tell us about how that's worked.
So hello, I'm Carla. I'm a psychologist and associate psychology training director at Salud. And so just to let you know a little bit about Salud Family Health Centers, we're a community health center with 9 clinics across Colorado. We offer integrated primary care. We have a range of services: medical, dental, behavioral health, pharmacists, health corps members, care managers, just many team members. And we really focus on the underserved and reducing barriers to healthcare. So we've had behavioral health for the past 15 years at Salud, and in a very integrated fashion, I would say, for the last 6 years. And our innovation was actually not completely new to what we were doing. It was actually extending it a little bit. So our behavioral health providers, we provide universal screenings, consultations, and short-term therapy. And so we have some target groups that we like to focus on to screen, such as new patients, children, and pregnant or OB patients, and postpartum patients. So our innovation was, not only did we want to really kind of focus on our pregnant patients or OB patients and screen them, but also follow them if they are high risk. So when we screen for psychosocial stressors such as depression, anxiety, trauma, substance use, alcohol use, and cigarette use, and also we screen to see if our patients are in a safe living environment.
So let me stop you for a minute. So how do you screen? Tell us how that process works if you're from the patient's perspective.
So, we have such great medical buy-in at Salud. I would say our medical director, Dr. Tillman Farley, has always been a huge supporter of behavioral health. So when that patient comes in, it's our patient too, even though they have a specific appointment with their medical provider. So, we will see that a patient is ready, and, I always talk about the importance of communication in integrated care and make sure we're not disrupting the flow when we just go in and introduce ourselves, explain the importance of, the connection between our physical health and our psychological health, and we just start the screen. And we like to screen our patients at least once a year.
And tell us about sort of for lack of a better word, the curriculum or the protocol for the screening. You have is it sort of a clipboard style thing? Do you ask them to fill out some questions on a computer screen?
So when we start with our initial screening, the screen for life stressors that we have, we actually just ask it to them verbally. We really try to make it really conversational, and that's part of the reason we have our behavioral health providers doing the screening rather than doing it on a kiosk or something. We always like the idea of just having that connection. And then depending on if they screen positively, we would then give additional screeners.
And what point would you suggest to them that they might benefit from other help and maybe go introduce them to someone, or tell us about the next step when you've identified someone who you believe could use some more help?
Well, I think, in that conversation, once if we've given additional screeners, if we're talking about the familial stressors or behavioral health symptoms that patients are having, we might talk about some helpful interventions and then also talk about the benefits of therapy. So usually I would say, if we're, a lot of times we offer short-term therapy and we would meet with that patient later, and we would just talk about that, when it comes up, usually near the end of our consult.
Does it take a certain kind of provider to have those conversations, to be open to the teamwork, and how have you found those people?
What do you mean, a certain kind of behavioral
Just to be
health provider?
Behavioral or primary care provider, someone who's comfortable doing the
Yeah.
team setting and really doing the handoffs.
Oh, I think it definitely takes a certain kind of individual for that. I think you have to be open to being very flexible, both the behavioral health providers and the medical providers, because it is such a cultural shift. For the medical providers, knowing that it's going to be great to have behavioral health, but your flow may get a little disrupted sometimes. Your patients, it may take a little bit longer for them to leave the clinic because they are getting behavioral health services. And the same for behavioral health providers. This is not your typical 15-minute hour setting. You want to be available. You may think your schedule is going to look one way when you go in at the beginning of the day and may be very different at the end. So a lot of flexibility.
Great, thanks. We'll come back and we'll get some audience questions in a minute. Dr. Hammond, if you could talk a little bit about what Westminster's practice looks like and where you were in integration before you joined up with ACT and where you went after that.
Okay. Well, first of all, I disagree with Glenn. He says he's intellectual, but he sure sounds like he leads with his heart. I'm intellectual. So Westminster is a sort of suburban northwest Denver area, and we are in a working class community, and we've been a patient-centered medical home since 2009, so provide comprehensive coordinated care. And we had tried over the last 10 years to integrate behavioral health into our practice on 3 separate occasions and failed each time. And this time we were hoping to get our act together, so to speak. And,
Hold on a second, but wait, let's talk about failure for a minute, if you don't mind.
My favorite subject.
Because that's where we learn, right? What failed? What were the things that you tried that just didn't work?
Well, I think, we did try to, I think it's economics, finances, and cultural differences that probably led to the failures. We tried an independent practitioner, and that didn't work out probably for cultural reasons. We tried to work with another group in West Denver, and again, it just was maybe the wrong time. We really didn't understand integration. We didn't know, I think, really what we wanted, and didn't put the right efforts into it. But money was always a big problem, just how to support it. And I think over time we got our vision together, and we're more specific and clear on that.
Okay, so when you came to ACT, you felt like you were more ready to try again, and what did you work on?
Well, I think it's also the patient barriers, and so I think we learned what the patient barriers were, and we wanted to address that. So we looked at the logistical and the financial aspects of getting people mental health care. We were like the 2/3 of physicians that cannot get mental health care for our patients. We were solidly in that bucket. And like Glenn said, when you did make a referral, the vast majority, 50, 70%, would not go or could not go.
So you didn't have it on site, so you would have had to refer them out.
No, at that time, because we were in between care. So this time we said, okay, we wanted to solve the logistical problems, get people on site, be able to have them see the patient when they needed to see the patient, if it was crisis right then and there, or a warm handoff as an introduction to improve the chances that they'll come back or through schedule. And we also wanted to break the financial barriers, and so we had basically 6 visits of short solution-based therapy at no charge, and then if the patient needed to get longer-term care, they were referred out to a community center. And then we also, understanding the other aspects of behavioral health, added in health coaching for our chronic disease management and diabetes and cardiovascular disease. So it was a rather 2-pronged, very comprehensive, integrated team approach.
And did you hire new people to handle some of this?
Well, yes, through ACT we were able to pay for a behavioral health person full-time in our practice, and also on our own we're able to, with encouragement, nice thing about being an independent practice is you can lose money anytime you want. And so we hired 2 health coaches to round it out.
Okay, great. I want to come back to how you found the right people in a minute, but let's talk to Jennifer for a minute. If you're ready, Jennifer, to tell us a little bit about when you came to Westminster for help and what you needed, and then how they helped you through their system.
Well, I started off, we moved here from Tennessee, and started off with a different practice, a different doctor group. And I have knee problems. I was having trouble walking, have just some traumatic stuff. So I have PTSD, and just was not, all they wanted to do was just keep giving me medicine. And there was no help. There was no, a counselor could help you, or physical therapy. It was just, here's another pill, here's another pill. So it just got really, really old. And we moved to Westminster, and when we did, my mom started seeing one of the doctors at Westminster Clinic, and she loved them, so I started going too, and now like my whole family goes there. But yeah, so, but the difference was when I told my doctors at the old practice that I was feeling blue, or, just like I can't drive at night because I'm afraid of, who's gonna pop out in my back seat or whatever. And they had nothing. We'll carry mace. It was just very cold and very, you have to get over it's in the past. And then coming to Westminster Clinic when, I still having trouble walking and a lot of other stuff, it was amazing because I'm trying not to cry, sorry. That's why I'm repeating myself.
That's okay.
But,
So tell us, when you went to your first appointment was a physical appointment.
Yes.
So what happened at that physical appointment and that was different than your other experience?
Honestly, I just kind of like bleh, all over. It was just like, this is what's going on, and I smoked 2 packs of cigarettes a day, and I'm horrible, and please, I want to get healthy. And but Sarah is who I saw, and she just was like, she just took time with me. I mean, it was just like I didn't feel rushed. I felt that she really cared about why I was there, and like helping me. Mm-hmm. And just that in itself was like, oh, okay, maybe we can get somewhere. And some people have already asked me where I have a dog that I bring. He's emotional support animal.
We were hoping he'd be up on stage.
I know, and I wanted to bring him, but he had knee surgery, so that's why he's not here. But this is the first time, other than getting in front of, I teach theater and I'm a director, being in front of my parents, this is the first time I've been able to actually be in front of people in a good 6-7 years. Wow. Without my dog. So,
nice.
Yeah.
Well, thanks for doing it. I want to hear more about what happened next with you, but I want to ask Dr. Hammond to talk here about the time factor. How do your people have the time, instead of a 15-minute physical appointment, to, if it takes half an hour, if it takes 45 minutes, it takes an hour and a half, can you factor in that time to have the long conversation to get a full patient history?
I don't know.
Is that where the money-losing part comes in?
It seems that happens. It happens. Time happens. Well, we have worked very hard on team care and the culture of the practice and the medical value of beneficence, where the patient, the interest of the patient comes first. So it happens, and our patients understand that we're late, and we give the care we need when we have to, and it all works out by the end of the day. But I think it's because we're a patient-centered medical home, we're efficient, and we're able to use our team to its highest level of their skill set, and we're able to get a lot of things done.
Dr. Kotz, you want to talk about time for a minute? How do you schedule? Do you schedule differently than you used to? Do you have discussions, arguments within the clinic about time slots and how to make them work?
Yes.
Who wins?
Well, I think that, as Dr. Hammond said, we're in private practice, so we have the privilege of losing money. How do we schedule? It is, at some level, control chaos all day long. We do, huddle, we have an idea of what's going to happen for the day. We have an idea of who's going to be seeing mental health, behavioral health, who's going to be spending more time with the staff. But when the day evolves, it's just chaos. Chaos being very controlled. I'm not saying it necessarily always in that negative phrase. What goes on in all of our practices really is saying, well, this is what the patient's needs are. And we need to meet those patients' needs. How does that happen, and how does a day evolve? It just evolves as the patient's needs are at that moment. You know, we started talking a little bit about trauma, as Carla started to mention a little bit. We are learning about trauma-informed care in our practice, as I'm sure each of the practices in ACT are doing. And trauma-informed care is a completely different way of looking at an individual as they're in the office. We do a lot of adverse childhood event screening. We have some ideas about what trauma is going to be that day for that individual, but not always. So, you know, the idea, and it's very, very important, I think, for us to understand that when a patient walks in for a diabetic visit, the purpose in our minds is they're there to review their hemoglobin A1C, they're there to talk about whatever, and they come in and they say, but I'm getting a divorce. Well, the provider generally would say, well, that's really nice, but boy, your hemoglobin A1C is going up. Well, the patient really doesn't care about their hemoglobin A1C at that moment in care. This is now a trauma visit. And understanding that that trauma visit takes precedence is a different way of practicing, and that's very important for, I think, all of us in primary care to understand. So the day just goes that way.
Okay. I think Mindy wants to jump in. Go ahead, Mindy.
You know, I think when we look at what time is necessary to make integrated care successful, it's not only looking at the provider's time with the patient, it's also looking at how do we ensure that the providers have time to talk to each other. So how do you make sure that the behavioral health specialist has time to talk with the primary care provider, and the primary care provider has time to meet with their whole team? And, you know, you can't talk about provider-to-provider consultation and team-based care without then going to payment reform. And I don't
So how
mean
do you do that? How do you make that happen? How do you give that provider-to-provider time?
Well, currently, the way that we're able to do that is by eating the funds, you know, by securing community resources and grants to give us some ability to flex time. But, you know, that's not sustainable. And so for the long term, what we need to look at is a payment methodology that really supports what's necessary to make integrated care fully effective, and to move away from any kind of payment model that is based on volume.
So you've got your psychologist, your doctor, your mid-levels, case managers in a room talking to each other about what's coming up in the day and the patients that they're going to see, and nobody's paying them for that time. You're paying them, but nobody from outside is paying you, right?
Correct,
Is that the problem?
correct. And
Okay.
in the model that we've moved to, and we weren't able to do this as part of our ACT intervention, but in another clinic where we have a little bit richer grant support, what we've been doing is not only including those folks that you're mentioning, but also our navigation team who works on helping people to secure affordable housing and other things that help with, you know, impact the social determinants of health. And, you know, we're really trying to make it everyone who comes in contact with that patient is meeting together and talking about their complex needs and how to best support them.
Yeah, go ahead, Glenn.
Mindy, thank you for bringing up sustainability of a program. So I'm going to change a little bit to a business model. And I'm just like Westminster and Dr. Hammond, where patients are in a medical home. So I'm going to talk about money a little bit on the western slope, which is going to be different than the front range a little bit. So the average cost per member per month on the western slope is right around $450 per month, per member per month. That's the average. I live in the Roaring Fork Valley, which is the most expensive healthcare community in the country. I don't know what the cost is. The cost per member per month in our practice is about $460, $470 per member per month. And that's really a lot because of our behavioral health integration. And I'm a member or a practice in CPC, which is Comprehensive Primary Care Initiative. I know that the highest cost per member per month in our valley is almost $1,200 in the CPC network. These are transformed practices. I do not know what the untransformed practices are. They would have to be at least $1,000 PMPM. So if we're looking at dollars now, we are saving the system at least minimum $500 per member per month. And if we have a minimum, and actually we have more than 2,000 patients, I'm just going to round this off. So if we have 2,000 patients and we're saving 500 PMPM, that's $100,000 a month. That's $1.2 million a year minimum.
So why are you saving money? Is it because your patients are not showing up in the hospital? They're not showing up in the ER? What are they not spending money on?
They are not being admitted to the hospital. They're not being, they're not doing the referral downstream that happens with behavioral health people. So the behavioral health people in traditional primary care have none of, they don't really get their primary, their foundational needs met, meaning the behavioral health needs. We're meeting their diabetic, whatever, I'm making a lot of faces because at some level they're all trivial, but we're meeting those needs. But they're still searching everywhere in the healthcare system to try to meet their foundational needs that we're not meeting. So they see specialists, they see whatever the dynamic is. So if we're gonna pay for primary care and behavioral health, or vice versa in the same environment, that is such a small fraction of that $1.5 million saved to the system per doc per year. That's unbelievable. Why? So, and as Dr. Hammond said, and I'm just going to put a number on it. So last year, first of all, we don't make a lot of money. But integration of primary care and behavioral health, I personally lost $60,000 last year. So instead of having the luxury of the practice, I'm a solo doc, practice absorbing the cost, I absorb the cost. But I'm not going back. As we talked about in ACT, once we give better care, we can't look a patient in the eye and say, I'm sorry, we did a great job with you, it's over. That's just not going to happen. So what happens is that our primary care crisis is going to get worse. Either the docs aren't going to go into primary care is not going to be integrated, we're not going to get the healthcare needs met. The only people that are going to be doing this are Dr. Hammond, myself, who we talked with Deb Cohen before, are Dumb and Dumber in our idea. I'm the dumber one. But we're the ones that are just passionate about doing this and saving the system lots of money while we're losing money, literally losing money.
Carla, could you talk about what do you think happens with your patients in terms of both quality but also cost, in terms of pregnant women avoiding problems down the road? Do you feel that you guys are making a difference in what's happening with your patients in early intervention and progress later on?
Yes, I think that, being able to screen our pregnant patients at the beginning of their pregnancies and being able to identify any depression or anxiety or, for instance, cigarette use, alcohol use, substance abuse during pregnancy is so huge. And so, being able to work with someone to reduce their cigarette use, their alcohol use is just made, I don't have data for you right now, but it really makes a huge difference. And also just the things that come up during pregnancy. It's a really tricky time with a lot of different emotions. So being able to give that psychoeducation on postpartum depression, addressing depression during pregnancy, being able to give support, and really for our patients it became an expectation to start seeing us when they were identified as high-risk OB patients. And being able to see them throughout their pregnancy up to 6 weeks postpartum and helping them with that huge life transition, really anecdotally really helped.
Great.
Yeah.
I'll make sure we leave some time for audience questions or observations. So is there anybody who, raise your hand now, otherwise I'll ask another question at the moment, but make sure you chime in. So raise your hands. We have people in the back, Kendall and Jacqueline with microphones who can bring one to you. Kendall, it looks like somebody right here.
Hi, I'm Cindy Guillaume, and we're with Poudre School District in Fort Collins, and we have initiated a business healthcare partnership towards integrative care. And I'm curious to know if there's an ACT project in the state that's looking at promoting the partnership between business and healthcare.
Somebody from ACT want to take that one, either Maribel or Larry? Tell us more about the business connection.
Well, we actually established an employee clinic and a disease management / lifestyle health and wellness and an EAP behavioral health program in partnership. We went to our healthcare system, to UCH, and to our largest primary care group, Associates in Family Medicine. So we're carrying the business part of our responsibilities through sponsoring, providing the funding for our integrative health management system.
So you mean from an employer perspective?
From
you're
an
wondering
employer
if there's working,
perspective,
okay.
yeah, because you mentioned one of the obstacles is business and employers kind of not carrying their piece of things, and that's something that I think we're doing very aggressively. But it's interesting trying to work through and think through the barriers between business and the healthcare partnership. So we're looking at integration of behavioral health, medical, and then business responsibilities as well. We think that's pretty exciting, but we haven't been able to find anybody else that's working on an initiative like we are.
Well, hearing from ACT that they don't have a specific program with employers, but good idea for the future, and so they might want to talk with you. So make sure you link up.
Invite you to become part of the learning community as well. Yeah. We could learn a lot from you.
Great.
And vice versa.
Mindy, do you work with employer groups at all, or is there any connection there that you can mention?
I can't say that we have a pretty extensive community wellness program that we make available to different community members, regardless of if they're a patient of Jefferson Centers or not, and we have tried to reach out to businesses in that regard. We have had an EAP business line in the past and really didn't have much uptake of it.
Okay. Other questions from the audience? Looks like we have a couple here. Oh, okay, go ahead.
Good morning. My name's Miguel, and I work for Idea Forum. We're a drug and alcohol and domestic violence treatment agency. And my question was, both Dr. Kotz and Dr. Hammond mentioned that they started with a sort of a referral model and eventually moved to in-house as far as the referrals go. Would you guys say that's a total dead end there, the referral model, or there is some way that could end up working?
Dr. Hammond, that's a good question. I wanted to ask you then how you found the person that you did end up with and that did work out. So first, the question of is it to use his phrase, a dead-end model to have referrals?
No, I think that, as a patient-centered medical home, the next step in evolution would be a community-centered medical home. So you need to have connections with the community. The thing about the referral system that's dead end is that the system doesn't work and that there's not enough capacity in the behavioral health world to receive my patients. There's economic barriers that don't make it possible. So I think we do need to work together. There needs to be, I need access to specialty mental health. So even though I can take care of 80% of the mental health needs of my patients in my office, I still need the community. So in terms of how we found our people, in the ACT program, we partnered with Community Reach, which is a mental health center in Adams County, and they placed somebody and we paid for that person, but through the ACT funds, and they placed someone in our office, and that worked really well. Unfortunately, it was not sustainable when ACT sort of has concluded that person chose to go someplace else for a different part of her career, and now we are looking to partner with Jefferson Center to bring that person back in. And again, it's having just like-minded people who are visionary to make it happen and to absorb those sacrifices. But the economic model for us is not there. We have to depend upon the community to make it happen.
Mindy, you get referrals still, in addition to having people in-house, right?
Oh, absolutely. And,
yeah.
and I think that one of the things is that you really need to look at it from the perspective of a healthcare neighborhood, because you have to respect patient choice. And, having primary care available on site doesn't mean that all of your patients want or should go to see those providers, and having behavioral health on site doesn't mean that all of your patients are going to be appropriate for that provider and not need specialty referrals. And so I think that, integrated care is not in and of itself a panacea. We really need to be looking at integrated healthcare delivery systems within a community. And beyond healthcare, we need to be looking at human services, and how do we make sure that all of those connections are in place. Oh, I love that you clapped for me. I'm so excited.
Yeah. And there's also two more questions over
I
here.
was going to add to that comment, though, before the next question, is that, the model is not, the current model for primary care is not sustainable, period, end of story. Healthcare reform is really just inadequate repair. And so our practice is looking at direct primary care as the only viable economic way to be able to provide the innovations that we want to do. And I'd suggest to the lady over here who's looking to partner with businesses and primary care to look at Nextera up in the northern area that's doing that right now. And I can talk to you later about that.
Yes, you two link up after, and we'll talk some more. Kendall?
Good morning, I'm Eric France. I'm with Kaiser Permanente. I'm curious, two questions for the Westminster practice. I didn't hear the second half of Ms. Sharp's story, and so you had the time to see the physician longer, but then I assume it was walking out the door and meeting with the behavioral health specialist in the facility. So I wonder if you might say just a few more words about that piece. And then Dr. Hammond, I was curious about whether, and maybe Dr. Kotz as well, that does this change your reputation in the community, in that you get more referrals, friends saying, gee, you got to come to this practice? And so is there a growth strategy that sort of plays off of your medical home and having behavioral health in your facilities?
So Jennifer, what happened after your physical appointment? What did they recommend, and what did you do next?
Okay, at first, well, there's a chiropractor on staff there, and that was the first. So I saw him and Dr. McNabb, and then after I saw him, then Sarah came and checked on me, see how I was doing, and then asked if I wanted to see the counselor. She's like, I know you just met me, but I think there's some stuff going on. And I was like, okay, sure. And I saw her that day. It wasn't a matter of me leaving and then changing my mind, like, I don't really need to see a shrink. It was just, I went that day. No offense, that's just a word.
There's lots of them here. So.
I know, it's okay, you guys are awesome. But yeah, but being able to have them in their office, just as a patient, it kind of was like I didn't have an excuse not to go. It just made it more accessible and more like, wow. And then I left there just feeling, for the first time in years, just so valued as a person. But I mean, other than my family, obviously, but and as a patient, I wasn't there just wasting their time, or I was there because they cared. They didn't just want my money, and I know money's important, but yeah, if that makes sense. Did that kind of answer your question? So, and then when I was having the terrible migraines, it was a matter of, well, you are really stressed. The chiropractor could adjust me and everything and say, your stress point is really tight. You need to go see the counselor. Okay. And it was usually the same day that I got to go, and I don't even have a stress point anymore. So it's just really cool. It just hugely changed my life.
So Patrick, do you want to contribute to that?
I feel similar to Jennifer, and I've been an entrepreneur my whole life, and I work with organizational change as an entrepreneur all the time. And so back to your question earlier, and in that moment in time, what changed is kind of the question. And you changed. You changed is what changed. I didn't change. I was sitting there ready to be told how healthy I was or I wasn't. And then whatever it was, and I didn't realize it was another 20-minute module that I now know. I knew I was part of a project. I didn't know I was the project. And then Glenn sits down, and in that moment, he doesn't say, here's how you are. He says, how are you? And then I say, I'm afraid. That changed. The gentleman yesterday
going back to work, I'm afraid. What creates the environment to have any of us do what you did, Jennifer, to say, I'm afraid? And once we say that, you shuttle us in the next room and we're off and running. So that was my experience of change, that you changed, I didn't.
So Dr. Hammond, the other part of that question from the audience was, so when this kind of thing happens with Jennifer and Patrick, what happens with your reputation in the community? What happens with growth of patients? Was that your question, Eric? Okay.
Kind of a little, I have a little answer.
Yeah, sure.
So it went from my mom going to the practice to my mother-in-law going to the practice to me going to my husband to my 3 children to now like 4 of my neighbors go and a handful of people from my church go. So it went from just one person to at least, I want to say probably 15, 18 people go. So yeah.
So now they need to add a vet and then your dog can go.
I know, right? Yeah, then Loki can go too.
So Dr. Hammond, bigger picture from all that, where has that left you?
Well, I was just listening to that and I just lost my train of being a patient-centered medical home is expensive. And having, I'm sure we have a reputation. I'm sure I have a reputation. I'm not quite sure what it is. And yes, the word of mouth, patient word of mouth has always been the best source of new patients. But my mantra has always been is, work to my best, do excellence, and then, you'll be rewarded. But when that's not happening, and it's not a good business model, because even having a lot of patients that, come in that don't really cover your expenses, doesn't really matter how many patients you have. So it's what we do, and it's who we are, and I'm happy for our reputation, but it's not a business model.
One more comment, and now we got to wrap up. So let's take one from the audience, and then feel free to harangue this whole group on their way out the door if they're hanging around all day, which is what we really want, if they will. So one more question from the audience.
Sure, I'll try to be. My name's Jessica Dunbar, and I'm from Rocky Mountain Youth Clinics. And we have a similar model where we have behavioral health counselors, dietitians, social workers, and a dental hygienist and a dental assistant working in our clinics. And I just wanted to comment on the team communication piece. And nobody has mentioned yet how important the space configuration of the clinic is. And I just wanted to say that we've had a lot of success with a hub and spoke model where between appointments, everyone on the team is in the middle, and they're constantly sharing, consulting, communicating with one another. And in one of our clinics where we have a longer hallway, it's been more challenging just to have that natural, discussion and sharing. And I was wondering for some of you, as you've gone about advancing with the integrated model, if you've actually had to change even the way that your clinic is organized.
Dr. Kotz, why don't you answer that one, and then we'll have to wrap up. But yeah, have you changed your physical space as a part of all this?
So luckily, and I want to thank my wife, Lisa Robiano, who works with you guys, and we have school-based health programs as part of our kind of network. Luckily, our space is so small that I think that probably Dr. Smith and I spend most of the day probably this far apart, so we have a very high touch factor is the phrase that we've been using in ACT, and I agree with you 100%. And Michael, I'm going to dominate for a second. I want to go back to your statement, because I think it was very important about kind of referrals and behavioral health organizations. And we all start having negative experiences and create stories in our heads. And my story was, boy, when I try to refer somebody out, I never hear anything back. So it's the black hole. And what we have found in our community is the behavioral health organization has no money. So when we ask for communication back, we found that their therapists who are very committed, they're the ones that have to copy the records and send them to us. There's no front desk person doing that. we found that there are more and more barriers to say, well, gosh, the patient has to sign these 12 different releases for me to even acknowledge that I saw them, even though you referred them to me. So I think as we move into this world of coordinated care, something that needs to be broken down in a bigger system is allowing the behavioral health entities to communicate easily with primary care from an outside standpoint.
Great, that's a great way to end. And we, the foundation policy people and many other partners around the community are working on trying to help break down those barriers, and we'll be talking about that in the next issue of Health Elevations as well. But thank you all, panelists, for your time, sharing your personal stories, being honest about things that haven't gone well and that we can work on. Thank you so much for doing that. Everybody, please be back at 9:45. Thanks, everybody. Hope you all got some hot coffee or tea. I've heard the room's a bit chilly. So get that close personal space and high touch we were talking about. One of the remarkable parts of ACT and the ACT effort is that all the partners committed to not just experimenting, but to evaluate and measure how those experiments turned out along the way. I come from a journalism background where far too often we would write a big story and declare something awful or that something needed to change and then never follow up and say what happened afterward and if anything ever did change. And ACT is always committed to that. So I'd like to introduce Deborah Cohen, who's been there from the start with ACT in order to be able to tell us what happened next. She's an associate professor of family medicine at the Oregon Health and Science University and has been a principal investigator for a number of federal and foundation funded grants. So Deborah, come on up.
Thank you. It's really a pleasure to be here. So I've had the chance to work with Larry and Maribel and the people in the program office and all of the amazing ACT innovators, the steering committee, who has an incredible lead to do what is one of the most interesting and exciting programs I've been involved in. And we had the opportunity to do an evaluation with this great group. And I'm going to tell you a little bit about what we learned. And my comments are probably going to echo those that you've just heard from the panel, but are going to talk about them in a way that hopefully spans across the 11 practices. I'm not going to get into a lot of the details about the evaluation. It's highly recommended that perhaps I not do that. But suffice it to say, I look nice today, but we were pretty much crawling on the ground with the ACT innovators most of the time. We were really trying to understand and touch and feel and sniff and taste what it was like to do integration in their clinics. And that meant that we went out and visited, we watched, we talked to people, and we collected all kinds of information, and frankly, we couldn't have done any of that without them. I couldn't be here today telling you about what happened. So our deepest and sincerest thanks. I do want to mention that at the same time that we were studying the ACT innovations, we also had the privilege to study 8 other practices that were sprinkled across the United States. And some of the comments that I'll make today will be tying in some of what we saw at those practices as well. They were practices that were, in some cases, integrating care a little bit longer than the ACT practices had, but they just had a different flavor, a different location, and I will draw on some of those experiences as well. So in the last 3 years, we've been in 19 practices, both community mental health centers and primary care practices that have been working to integrate behavioral health and medical health care for their patients. So my talk is structured around 5 organizing principles, and let's see if I can get this to work. Oops, I got it to work too well. All right, okay. I'm going to talk about 5 things, and I want to be very careful to point out that these are organizing principles that we did not make up or pull out of thin air, and these are the principles that emerge from careful observation and work of integrating care, and it's important to keep these principles in mind as we talk about integration, and it's also really, really important to recognize that these principles are interdependent and completely intertwining, and I'm going to try to show where some of those interconnections happen. So I want to start off by talking about integration reach. All right. So reach is a pretty simple and yet important idea. So very simply stated, when you think about who your target population is as a practice, your reach is your ability to reach those patients in your target population. And each of the ACT practices define their target population somewhat differently, but they each defined it. And each of them assessed and measured the extent to which they were able to actually get services to those patients in their target population that needed them. And what we found among the 11 is that there were a couple defining characteristics. The first is that practices sort of sorted along broad reach and limited reach. And those things really mean what they say, how they sound, which is some interventions were really able to touch a very broad swath of their target population. And some projects were more focused on a limited swath of their target population. And there are really good reasons for that I'm going to talk about throughout my presentation. But I wanted to introduce one of the basic ideas around this idea of reaching a target population, which is identifying need. And one of the things that we found was that for practices that were able to identify a clear target population, and for those that developed a routine and systematic way of identifying the need in that target population, they were able to actually fairly consistently identify and screen, in this case, almost everybody in their practice. And it didn't need to be fancy. It could be a piece of paper that got handed out at the front desk. It could be fancy. It could be a web tablet. But what tied this together was a clear definition of who the patients were, everybody in the practice agreeing on how they were going to systematically, every day with every patient, talk to them, identify need among those patients. Now, the other alternative was to not do that, and was to rely on what we've come to call clinician discretion. And that's essentially the identification of need when relying on clinician discretion. And there are really good reasons for doing that, which I'll mention. But essentially what happens in a clinician discretion model is there isn't necessarily a systematic approach for identifying patients or patient need, but oftentimes somebody comes into the office and there's an obvious red flag. Somebody's crying, somebody is upset. Glenn was talking about somebody who comes in and mentions right off the bat that they're getting divorced. In those situations, a clinician who has the time and resources can say, listen, there's somebody here who I think you should talk to, and we'll get that person to talk with that person. And you can just see what routinization does. Now, I'm not advocating for either approach. I just want you to see the differences in them, because what we've learned by looking at the ACT practices is that addressing need is kind of like forcing water through a hose, right? And you have to be really careful, and practices are very mindful of balancing the amount of water that comes out the hose and the size of the hose, because if you send too much water out, the hose is going all over the place, and you can potentially address more need than you've got the capacity to manage. But that balancing act is shaped by some of the other organizing principles that I'm going to talk with you about today. So this is just a great place to start. And it's a place where a lot of practices start, which is in thinking about how am I going to identify the need in my patient population, and how do I want to go about doing that? All right, so care continuum pathways. And we had a really interesting conversation about this on the panel. When faced with integrating behavioral health and primary care, practices need to take a very clear and careful look at themselves and figure out which of these patients can we care for in our practice, and which of these patients can't we care for in our practice. And there are going to be, every practice is going to set that bar in a slightly different place and in a slightly different way. But regardless of the need of patients, practices need to be very clear about the pathway for getting patients' needs met, whether it's physical or behavioral health needs, whether it's specialty and long-term mental health, or whether it's something that can take 4 to 6 visits with an integrated professional. But they have to sort that out. And it's really, really important. This is one of the areas where the hose comes back into place. So there are a lot of practices that, let me take a step back. One of the important pieces of this is knowing the community and the resources in the community and developing relationships with community resources. So there are a lot of practices that aspire to have what we think of as an integrated behavioral health primary care model, where practices like Scott's and Glenn's are working shoulder to shoulder with a behavioral health or primary care provider in their clinic. And there are a number of times when that aspiration isn't met because patients who would benefit from these brief visits in the primary care practice aren't able to be easily identified. And sometimes there's a mix of patients who actually have higher needs. And when those folks get referred to a BHC who's supposed to be doing a 10, 15-minute visit and who's supposed to be keeping their schedule flexible, that now can turn into a much larger visit. And we've been in a number of practices, and some of these aren't ACT practices, where folks that have aspired to integrating care, their system kind of gets clogged up because of a lot of patients with high needs not getting sent out and triaged. So really there's 4 key elements: setting the bar right for your practice and your patients, figuring out how to triage and hand off folks in different ways, establishing internal and external resources for this, and then figuring out how to follow up with folks. So someone in the audience brought up physical layout, and one of the things that we've noticed, one of the organizing principles is location, location, location. It really isn't much more than a hallway that can separate professionals. And what we found was that the need of, it's really important for folks to be close together. It promotes visibility, it promotes leaning over and saying, hey, have you seen Sally recently? What's going on with her? It promotes bumpability. I've literally watched people who would not have talked to each other about a patient run into each other and say, hey, I just saw a patient that maybe you should see. And it promotes what we've referred to as the 3 C's: consulting, coordinating, and collaborating. And these are interactional behaviors. This is interpersonal ways that professionals work together. And it's the 3 main ways across 19 practices that we saw behavioral health and primary care practices professionals working together. Consulting, asking each other for advice. Coordinating, when 2 professionals work in parallel and a back and forth faction, but are able to achieve common patient goal when delivering care separately. And collaborating, when 2 or more professionals actually put their heads together to figure out what's going on with the patient and describe treatment. Now, one of the things I want to show you is, and this is not, don't overly look into the numbers here. These are just some numbers that we put together based on our observations. But if you look at the total number of unique patients that we observed in ACT, there were 80 observed when behavioral health and primary care were located in close proximity, and 84 when they were separated by some distance. And what we saw were 39 instances of coordination when folks were in close proximity and 14 when they were further apart. So location is really critical. We observed 2 main types of care transitions: a referral, which is when a patient is directed to an appointment with another professional, and a warm handoff is when a clinician is directly introduced to a patient and another at the time of the visit, and that clinician may then have a brief visit with the patient. There were a lot of practices that we observed that aspired to doing warm handoffs and ended up landing in a referral model, and there are a lot of reasons for this, and some of which I want to point out. So the practices that were able to do warm handoffs had a few key features. They had professionals in close proximity. This is where we start to see these principles intertwine. They tended to have a higher BHC to primary care staffing ratio, somewhere between 1 BHC for every 2 to 6 primary care clinicians, but there's some wiggle room there. They had multiple BHCs on staff. People take vacations, they get sick. Stuff happens. They could help cover each other. They had shorter, more flexible behavioral health clinician appointment schedules, often with open slots. Those visits tended to be in the 10 to 20 minute range. And these are folks that tended to pay a much broader attention to the behavioral health needs of the population. So they weren't just focusing on mild to moderate depression, anxiety, they were helping folks that had diabetes and folks that needed blood pressure control. Those practices that aspired to do warm handoffs weren't able to accomplish this because folks were on different floors. It's amazing how much a floor makes. And we've had folks where the leadership aspires to having integration, but their psychologists are on the second floor and their primary care teams are on the first. They often have a lot of pre-scheduled visits. So these are often places where a day is booked, whether it's with 30-minute visits or 50-minute visits. The behavioral health schedule is booked for the full day because that's how they get paid. They tended to have longer visits, 30 to 50-minute visits. They tended to be caring for more serious illness in-house in the practice because they either didn't have a relationship with specialty resources in the community, or that was really where their behavioral health clinicians felt most comfortable. And there's one more important element that also shaped this, and this is one of the most important things, and it's a shared view. There were a number of practices, and I'll just briefly tell you one story where we were in, and it actually wasn't an ACT practice, and I'm sure this also applies to ACT practice, but one of the most compelling stories was a very outspoken medical director, actually the director of integrated behavioral health, who desperately wanted to integrate behavioral health and primary care in her clinics, and for whatever reason, she had us visit a practice where this wasn't working particularly well. Her primary care teams were on the first floor. You had to go up 2 flights of stairs to find a psychiatrist and a psychologist. And truthfully, when you spoke with those folks, they weren't really comfortable working with primary care. You know, when you looked around, yeah, the space was hard to renovate, but they could have located a behavioral health clinician downstairs, but they just weren't of one mind on this. And if you think about integration and you think about it at each and every level, the interpersonal level, the practice level, the state policy level, it is this sort of one-mindedness, this sort of culture change that is at the heart of breaking down these silos. And it is not easy, but it can be done. You know, so when I think about the implications of this, I think about my own state of Oregon to some extent. There's a lot of similarities. And I was just telling Frank, you know, I've done a lot of interviews with folks, and typically at some point, you can come to some, you know, you get the sense, yes, you're taking a multi-perspective view, and yeah, there's a lot of different ways of looking at the chair. But at some point, you all agree that you're looking at a chair. But when you talk with people about behavioral health financing or financing of integration, I have yet to see where those things align. It's like you're getting 5 completely separate stories. And I actually think that it's true. I mean, we've cold called a couple people at our Medicaid, our department in the Oregon Health Authority that pays for Medicaid. And I think if we called each one of those people, we'd get 3 different answers to some of these questions. But this is you know, so it's complicated and it's hard, but these are all solvable problems if you start to try to get to the bottom of it. And I think that that's true at all the levels. So I just want to say that what we've seen across ACT is it's an incredible journey. The folks that are working on the ground are really doing hard work, not just to work with patients, but to get paid for what they're doing. It is not easy. Sometimes there's a ton of paperwork, too, to get done in order to get paid for what it is that you need to do. But you guys are on a super path. I mean, you've made incredible headway. We've learned a ton from ACT. And I know these 5 organizing principles don't sound that impressive, but man, if you can focus in on those 5 things, you can figure out how to build a program, because ACT has shown you they're important. So thank you for the opportunity.
Thanks, Deborah. And we're going to have Maribel Cifuentes come up and talk with Deborah and with all of you. Maribel has been the Deputy Program Director of ACT along the way and is now busy with Larry and Deborah and others authoring a series of papers that'll come out later in the year, expressing everything you've learned out into the world. And even just as important, Maribel has hands-on experience in the neonatal unit at Denver Health and other places as an RN, so she has actual practical experience as well.
Thanks, John.
So Maribel, did you want to start asking Debbie or commenting on what her observations have been so far?
I have one question, just to kick us off. and it kind of ties to the 5 organizing principles, but also to the previous panel discussion with the innovators. We hear a lot that there's this great importance in finding the right person, right? Not everybody is made for an integrated care environment, and this finding the right person is really, really important. And we agree with that. We think that's true for behavioral health and for primary care. However, we think it's a two-way street as well. And so my question to Debbie would be, for those practices, whether they be a primary care clinic or a community mental health center, just getting ready to start this journey, right? Of the 5 organizing principles, how could they think about what is the most important thing to get started on, to really ready the way for that right person to come in and fit and work?
Yeah, that's a great question, and I'm not sure I know the answer, but I can share some of what we've learned from the practices. I think that there's a combination of knowing thy practice and knowing thyself that are really important. I think that practices really need to understand the population of patients that they serve, because that can help them figure out how they want to focus their initial efforts on integration. And there's some benefits to figuring out how to start small and then grow it. So I think if you're a practice that knows that your patients really suffer from a lot of chronic disease and comorbidity and maybe mixed in with some depression. It's probably true of most primary care practices, but really kind of figuring out how to focus on those patients and identify them can be helpful. Now, that's not my general overall view. I believe that practices should be integrating care for all of their patients. But I think that when you start, especially if you're a small practice, and you're only going to have one behavioral health professional, and you may not have that person full-time, that being very practical about how you want to focus initially and is helpful, because what I've observed in ACT is A, the incredible resilience, and B, the incredible capacity to then scale up. So all of the basic behaviors that you need to figure out how to do things systematically, how to understand your workflow, how to communicate with your BHCs, how to work with folks in the community to care for patients, all of those can happen in a relatively small microcosm. So that would be one place to start. Know thy practice, workflows, and all those things. I think know thyself is important, because practices come at this frequently with we have to find the right person. And I think what we've seen across ACT and across other practices is that it almost always takes 2 to tango. And when you're working on teams, it's probably 4 or 5. So finding someone that fits your culture, but also figuring out how your culture is going to need to shift, essentially, to accommodate a new perspective, a new person who's going to be relating with your patients in a way that, is different from the way that you relate to them. That's a big transition, I think, for some folks, and it's a huge culture change. So I don't know how you prepare for that, other than to be aware that it's going to be bumpy. And then an incredible amount of flexibility is necessary. So if I were hiring, I would want to make sure I were hiring someone that were incredibly flexible, that weren't tied to a particular model, a particular way, that needed notes structured in a particular way. I think that I'd look for just an unending amount of flexibility. And then I would hopefully be able to look for some of that in myself and my team as well. But that's spoken as a true PhD. So I only watch. I don't have to do this. Thank goodness.
One of the things that Maribel and Larry have talked about in their wrapping up is the need for new kinds of training, new kinds of people. And I'm wondering if you heard people say that to you. They need to send us people who are trained in a different way than they used to be trained.
That's absolutely true. And this is another one of these crazy things about integration. So I can share more stories from Oregon here than I can from Colorado, but suffice it to say, we've definitely heard that that's the case. And the practices that are what some practices are doing is that they are training their own, either through postdoctoral programs or through other types of programs. But here's the crazy thing that happens in Oregon, and you can tell me if this happens in your state too. So social workers who want to be licensed clinical social workers and psychologists come out of these training programs. And these training programs, there's a couple that train them to work in integrated primary care practices. But unlike their medical counterparts who come out of a medical training program and go into a residency where they can get their clinical hours in and practice and bill for that and get paid for it. The way it works in Oregon is that when you come out of your social work degree or psychology degree, you have to do a number of hours before you can get licensed. And those are not paid for. And practices cannot bill for them. It's crazy. So there's a real problem. And now that the programs are training these folks, Oregon feels like they're losing people in this transition, that they can't actually get them to practice in primary care practices because there's no money to support the work that they have to do before they can get licensed and billed. And it's a totally fixable problem. But nobody's fixing it. And I don't know, is it the same here?
Yes.
I assume so.
Any fixes available for any show of hands? Who's got the brilliant idea to fix the problem? I mean, how do you get that group paid? Do you have to get a
create a
grant or
residency.
something? Okay.
I mean, we do it for primary care. We do it for every other profession. Why don't we have a residency?
Partner with business and get a different funding model.
Yeah, that's one option.
Yeah, I don't know.
And the problem's even bigger if you're in rural Colorado.
Right.
Is another thing to bring up too. Not only are there not enough behavioral health providers and primary care providers that know how to work in an integrated care model, but if you're in rural Colorado and you're trying to find somebody like that to bring into your setting, that's a real uphill battle. And I'm looking at Glenn and Corey. I don't know where Corey went. There's Corey right behind him. Glenn had to recruit from outside Colorado, actually, to find an integrated behavioral health professional for his practice.
So Maribel, can you talk a lot about what university is working on in these areas? Are they working on some of these things? And I'm sure you guys are encouraging them in that direction.
Well, we're certainly always working on new and innovative ways to teach family medicine residents to practice in an integrated care delivery model. Our own residency program, Department of Family Medicine, also has behavioral psychology interns that are part of that program, and a director of behavioral health who's actually here in the audience, we really work in a very integrated care setting so that when those residents do graduate, they know how to work in a team, and so do the behavioral health clinicians. And then there are some efforts to do telemedicine as well. That's another approach that I don't know a lot about. I bet there are other people here that know more than I do, to try to bring the necessary workforce into those areas that are so underserved.
So Texas just went in the other direction on telehealth and said that I think a physician-sponsored effort to say that they will not be paying for telehealth in the same way that other states are moving in completely the opposite direction. So sorry, Texas, but
Interesting.
Not a great shout out for them. If you could talk a little bit about the flip side of the paperwork that people talked about and the heavy bureaucracy that goes along with it is patient privacy. I was surprised that people on the panel didn't bring up more often cases of patients saying, wait a minute, you're going to share that information with either my doctor or my behavioral health person.
So I have yet to talk to a patient, and we've talked to some, not a lot, who actually cares about that. So let me be really clear. If I were a patient and I were under the care of a doctor who had me on a medication and a mental health provider who had me on a medication, my doctors need to know about this. And I think that the reason why this didn't come up is because when you have a behavioral health clinician that's working in your primary care practice as part of your team, couple things have changed significantly from a traditional model. The first is they're not writing 3 pages of notes about a long, detailed patient history of illness. They're writing 4 sentences because those are the 4 sentences that the primary care provider needs to really understand what's going on. What they've figured out is how to identify the kernel of information that's needed. The second is they're documenting in the exact same electronic health record. So they're part of a team who's sharing this information. These information sharing issues come up the most when you're dealing with traditionally trained mental health providers who tend to be working for a separate organization from their primary care practice, in my opinion, where that information now needs to be shared across organizations and across people. And it seems to be that this issue, I believe I got heckled once by a substance use provider. This issue seems to be the most significant with folks who are doing substance use counseling, who are very concerned that somebody's, substance use issues, and rightly so, are going to embarrass them. But that's not the piece of information that other providers need to know. They just need to know enough to be able to make sure that they don't do anything that harms the patient. So the way organizations handle this is they talk to patients about it. They let them know that in order to provide good, whole person patient care, that there's going to be some aspects of their information that they need to share. And I think that, I would guess that the majority of patients are okay with that. But that's an idea we could test.
Mindy, doing double duty is asking questions from the panel.
You do. I know you ask patients this. You have them sign a release.
So I just want to say that I think it's way more complicated than what Debbie just said, because the piece of legislation that makes it more difficult to share substance abuse information is 42 CFR. Most people in this room have probably gained familiarity with it. The complexity comes in not only when you're looking at once you have a signed release of information, then you're good until you want to share that information electronically, and you need a health information exchange entity that supports information that can only be shared with a release. So there's a whole level of complexity when it comes to health information exchange electronically. And the other piece that I think is really important is that a lot of us are really wrestling with this decision around, is it ethical to share some information about a patient and not all information about a patient? So if you share the mental health only piece and not the substance abuse piece, is that ethical? And and a lot of folks are coming down on the side it's better to share some than none, but some folks are not feeling that way. And so it's a very complex issue that needs to be delved into much deeper.
And I would suffice it to say, and I think you would agree, Mindy, that yes, there are lots of technical and policy issues. There's also an enormous cultural issue here that needs to be tackled. And we can hide behind the policy and the HIE, but if we don't cut to the cultural issues about professionals maybe not wanting to share information, we're missing the boat. So yeah, I mean, you're right, it's complicated, but it doesn't need to be that complicated, probably.
One more question, then we need to wrap up. Sure, go ahead.
Deb Judy, Colorado Consumer Health Initiative. So I have to bring up the patient or consumer and all this. And I'm curious, because we've talked a lot about the practice, and I appreciate the stories we heard earlier, but I guess I'd be curious kind of more broadly in how you're measuring the patient experience and what you're doing in terms of evaluation.
Yeah, great question. And the short answer is not well and not easily. So we have had the opportunity to actually conduct one-on-one interviews with a subset of patients. I've not been able to share that information because we've just collected it in fairly recently. We had hoped to do a much better job of understanding patients broadly through surveys, but that part of our work was unfunded. So we've not done a great job at that, and we focused our energy of understanding what is happening with practices. I can tell you from the patient interviews that I've looked at that the patients that get to experience integration have very, very positive experiences, but that's very rough and probably not very satisfying to you at this point. But it's hard, it's really hard to do research that involves patients broadly. Getting folks to respond to surveys, getting funding agencies to fund that work, it's tough. And we had to make some really hard choices, I think, early on.
Absolutely, and we really, we saw that, I guess, as a second phase of the work. We really wanted to understand the implementation aspects of what does it take to do this in practice, and look at the patient experience much more broadly, as you described. We really need to get to the piece that really looks at the clinical outcomes as well. We're going to be looking at some of the cost. We're doing an expenditure study, actually, that will attempt to answer the question, what did it cost practices to actually do these interventions and to sustain them? And if we're able to get claims data, we're also going to try to do at least a descriptive utilization study to try to figure out, does this approach to care change utilization at all? So those are all things that are coming in the future that we hope to tell you more about.
There's a really interesting, just as an aside from ACT, there's a really interesting group in the UK called DIPIX that focuses just on gathering patient stories and then makes them available on the web, so that you can see clips of videos with maybe 50 other patients who have X, Y, or Z. And we actually are starting this in the United States. And there's an incredible opportunity to do this across the US with patients in all different kinds of areas. So there's definitely ways to do this and lots of opportunity.
Thanks, Debbie. Thanks, Maribel. Sorry, we need to move on to the next segment. There will be a lot more information coming out in the fall, I think you said, Maribel, with the papers. September? Great, with the ACT paper starting to publish. So the next part of our program is that sort of larger, wider Google view that I mentioned to you, the world view, the United States view from our friends from Boston. So Dr. Mary Jane England is Clinical Professor of Health and Policy Management at the Boston University School of Public Health. She chairs the ACT Steering Committee, and she's here to expand that wider view. What struck me listening to Dr. England, we were talking on the phone in preparation for this, is that she talked about how certain that she is and that others are that ACT is producing, and ACT and programs like it are producing results that can be seen and can be measured. And that, as she put it, when an insurance company or a government agency sends a check to an integrated care provider, as you put it, they should know they are paying for science. And I thought that was a great way to put it. So, Dr. England, thanks.
Thank you very much. It's really a pleasure to be here with all of you, and many of you I've known for now 4 or 5 years, some Larry and others for even longer. And I want to thank each and every one of you that was so involved with ACT. As chair of the steering committee for ACT, I have really learned a great deal, as I know many of you have, and I think it is a model for the nation. But we, as we just heard in the earlier discussions today, we have a lot further to go. And it's an important contribution, and again, I thank you. It is my pleasure today to introduce to you a man who I've known for many, many years. Bill Beardsley is a child psychiatrist, as I am, and we share many of the same values and advocacy points of view that many of you in this room do as well. Bill graduated from Case Western with his MD, went on to train in Boston, and never left us. He trained at the Mass General and then at Boston Children's Hospital and the Judge Baker Clinic. He has had numerous awards, including an honorary degree from Emory University. He has mentored wonderful, wonderful scholars and researchers. His career has been one of clinical as well as research. And about 25 years ago, he had a aha moment and said, all of this that I know, I want to put it to use for policy and advocacy, and became far more involved in policy and advocacy than he had in the past. He's a leader in research in children of parents with affective disorders, and actually has developed programs, public health interventions with families in Finland, Norway, Costa Rica, and the United States. He has a passion for little children, has worked for many, many years in Head Start programs in Boston and other places, the Boston Medical Center, and increasingly doing research with those groups to actually understand the dynamics with the families. He has spearheaded at the Institute of Medicine an approach to look at families, depression in parents and the impact on their children, leading to an IOM report, which I was privileged to chair. He has gone on to actually kept that alive at looking at children and families at the Institute of Medicine. And his research really has been crucial in leading us down more and more an advocacy path, and also a public policy review and understanding of children and families. And so I think what has more recently, he's become involved in the whole area of prevention, not that he hasn't been involved in his whole career, but worked with, many of you know Carl Bell, in a IOM report on prevention for mental health and substance use issues for children and adolescents, and has done some really important work which he will share with you today. So it was with a great deal of pleasure that I introduced to you Dr. Bill Beardsley.
Well, Mary Jane, thank you for that wonderful and overly kind introduction, and I would say the most important part of it is that Mary Jane and I are fellow travelers on a journey and share many of the same ideas. I want to thank all of you. This has been an extraordinary symposium. Patients, family members, practitioners, policymakers, Colorado Health Foundation, really an extraordinary set of achievements. I celebrate with you, and I will urge you to move forward and think about, well, looking forward and looking backward, an enormous opportunity in Colorado. And I had prepared a lot of remarks about the ACT program, but I think I read all the papers, and I think it's a fabulous program, and I think the presentations today are more eloquent than anything I would say. I would only highlight 3 areas. One is this is very planful, with an idea from the beginning that these practices would be developing ideas that could eventually be widely used. Secondly, it's been carefully studied, both in the reflective practices of the people doing it and with the work of Dr. Cohen, and evaluation is absolutely crucial. And thirdly, it's moving somewhere to much broader implementation. Now, I had tried to think about what would be a good theme for this talk, and I love sports, I love to play sports, and I thought about a sports analogy. So I grew up in Atlanta at a time when there weren't any professional sports, and didn't pay a lot of attention to professional sports. And then I came to Boston, where there's a fantastic fanatic interest in professional sports. In fact, I work at Children's Hospital in Boston. Most people don't think about that as the location of a hospital. It's less than a quarter mile from Fenway Park. And we just had opening day yesterday. And we have, as you do in Denver, a hockey team and a basketball team, and we even have a football team that played well this year. So, and then we have 4 kids, all of whom were athletes. And so the sports saying I want you to think about is go big or go home. So think about it. You have an extraordinary opportunity here, and you can really take it to the next level. And I would say, very much following what Mary Jane has said, much of my career has been as a physician scientist and then as an advocate. The science is very much on our side here. We can do much more to help children and families in an evidence-based way than we ever could in the past, and we need to think about how to implement those things very widely. Starting, I think, with the notion that children are the embodiment of a family's hope for the future and central to the family's narratives. We need to think about how then to position our resources to maximize the likelihood that children will reach their full potential and parents will reach their full potential. I work from a human rights and a civil rights perspective. I think access to health care, access to mental health care, access to health promotion and prevention in both mental health and physical health are basic human rights and basic civil rights. We need to work from that perspective. But also, as someone who believes in democracy, I've more and more become convinced that we need to offer the same quality of care to everyone in the population. This leads us then to think about how do we implement and disseminate the very ideas we've been talking about today widely throughout Colorado and throughout the country. So implementation, dissemination is equally important. And what should a healthcare system look like that fully meets the needs of families, incorporates prevention and treatment, and reflects cultural competence and cultural humility? That's the question we've been wrestling with. I chair a forum on implementation and dissemination with Hendricks Brown at the Institute of Medicine that came out of the 2 IOM reports that Mary Jane mentioned. And what are the conversations we should be having in order to ensure that the healthcare system comes into being. I think the conversations in this room are moving a long way that way, but clearly there's much more work to be done. And finally, if we look backward, if you always do what you've always done, you'll always get what you've always got, okay? We need to think in very new paradigms and very new ways. And I think 4 constructs that really underlie prevention that are worth thinking about. First, developmental transactions. We want to think about how to maximize the likelihood that the interactions between the child, the parents, and the larger system are effective. In many ways, the single most important contribution to the development of the infant's brain is the relationship with the primary caregiver. How do we maximize that? The second is developmental trajectories. People are on trajectories. We want to think about how to change those trajectories so they are ascending. And finally, we need lifespan developmental perspectives. More and more we understand that early experience will have lifelong impacts on health and other matters. And finally, on the ground with families, I think we need to think about their narratives, how they see themselves, hear their stories, and think about how their understandings of themselves evolve over time, how their understandings of parenting over time, and of health. Now, we did these 2 IOM reports that both appeared in 2009, one on parental depression, one on prevention. And in the, well, can you give me the next slide? There we go. So, and I think the one other point I wanted to make, in all this work, Dr. King said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Now, he said that this at a time when we didn't have full coverage for all. We've been engaged in a grand experiment in Massachusetts to see how to do that. But I think, again, as we go through our work in primary care or in child psychiatry or in mental health, we need to be able to recognize injustice and identify it, as well as recognize the particular questions we're interested in. Now, coming to the IOM, we felt that it was very important not simply to talk about health as the absence of illness, but as a positive dimension. The 2 things we felt were most important were the mental health promotion aims to help individuals achieve developmentally appropriate tasks, developmental competence, work in school, home, faith, identity, to have a positive sense of mastery or well-being and social inclusion in that, and that mental health promotion strengthens people's ability to cope with adversity. I did a report with colleagues on prevention for the Institute of Medicine in 1994. That was chaired by Betty Hamburg and Bob Haggerty, and was one of the members of the committee again in 2009. And one of the striking differences is that, well, I want to go back to the slide that says prevention opportunities early in life. But if, you know what, we're not going to get there. So the slide simply made the point that 50% of adult disorders have their onset by age 14, 75 by age 24. Most disorders have symptoms which have onset 2 to 4 years before the full-blown disorder, so that if we're going to think about preventing mental illness, we need to think early, and we need to think about those things that will alter the developmental trajectories. Can you get me that slide? The one that had the diagram? It's the one before this slide. Yeah. Well, all right. So there's no way to back it up. All right. So then let me just try to describe this diagram, which came from the Institute of Medicine. Across the top are the developmental epochs of childhood: preconception, pregnancy, early childhood, school age, adolescent. Then we have a series of interventions that are backed up by the usual standards in science, evidence-based trials for the different developmental epochs. And then across the bottom, we have 3 larger areas. So early in life, first of all, planned pregnancy makes a huge difference. Secondly, high-quality prenatal care. After birth, certainly providing the environment that involves family leave or other ways to support parents. Clearly, there's very strong evidence for David Old's work, nurse-family partnerships, and other kinds of home visiting. Clearly, there's strong evidence for center-based care, early Head Start, and Head Start. As one moves into the area of school age, there's evidence for the value of academic interventions, social skills training, and clearly also interventions that strengthen parenting. And then moving into adolescence, we have pretty good evidence about substance abuse prevention. We have pretty good evidence about prevention of episodes of depression. I'll be talking about some of that tomorrow in the Levitt lecture. And we are beginning to have evidence that community-based programs with early recognition can stave off the worst effects of early psychosis. So there we are. So this is all what I've been talking about. But I want to come back to the bottom, because these 3, that we have probably the best evidence about interventions that focus on specific families' adversities, bereavement, divorce, parental psychopathology, parental substance abuse. These are areas where we have a very large impact, and indeed there are lots of commonalities across these programs, so that's one that can make a huge difference. A second is that interventions that strengthen communities, strengthen schools, for example, or community organizations, can have a very large effect. And finally, policy interventions can have a very large effect. A policy intervention would be to figure out how to adequately compensate people for doing behavioral health care well within family practice. A policy-based intervention would be to how to reward practitioners for taking care of families, not individuals, not diagnosis-based, but taking care of families and their broad needs. And certainly we've done a lot of work on trying to think about policies relative to maternal depression. I've talked about those preventions many of the, well, I'll just read the slide. Many of the generic features of preventive interventions that reduce or minimize toxic biological and psychosocial processes, richly reinforce self-regulatory prosocial behavior, teach prosocial skills, and foster acceptance. And finally, a central theme is that the scientific foundation has been created for the nation to begin to create a society in which young people arrive at adulthood with the skills, interests, assets, and health habits to live healthy, happy, and productive lives. So I think that's the background in science. We spent more time looking at implementation, how to do implementation. It's tremendously important. That's the issue that you all have been focusing on today. And we then did the report on prevention of difficulties in families with parental depression. These are some of the interventions, family talk, I'll talk about in a minute. I'm part of the Garber trial, which is a large, now in its 75th month, use of a cognitive behavioral group prevention for kids at double risk. Bruce Compass has an elegant family-based prevention for parental depression with outstanding results. Ricardo Munoz has an elegant postpartum depression prevention. All the work in mental health prevention relies on studying resilience. Across both reports and in a variety of different risk situations, there's very strong evidence for the value of parenting programs in terms of resilience. As we studied resilience in children of depressed parents, we found that their resilience consisted of 3 things: the ability to be actively involved in age-appropriate developmental tasks, a deep commitment to relationships, and self-understanding, both self-regulation and understanding in action, and above all, understanding that they were not to blame for their parents' illness, that they could help, but they were free to go on with their own lives. The same thing happened in studying the parents. Despite depression, many of these parents were extraordinary parents. They were committed to parenting, open to self-reflection, and committed to family connections and the growth of shared understanding. I think really good interventions are systematized common sense. We put this into an intervention called Family Talk. It's a family-based program, strength-based, series of meetings with parents and children, built-in follow-up, integrates treatment, but it's not treatment, it's all about integration. We basically take a history, do some psychoeducation. You're not to blame. This is not your fault. This is a biological illness. We see the children. We sit with the parents until they're ready to plan a family meeting. We then help them hold a family meeting to talk about depression and how to overcome it. We do a follow-up in a week. We do long-term follow-up, and we have an optional module where we do social skills training. And just one brief story, we worked with one mother who told us the following thing. I have a nice routine with my son. He comes home from school, has a snack, does his homework, we play a game, we do things together. But then when depression hits me, it all goes out the window. He comes home, I plop him in front of the TV, and I call his father and say, come home and help me out. What depression was then in that family was the complete breakdown of the routine for the child. And our work was then both to help the mother get treatment, but also to help her figure out how to get back to parenting this boy one small step at a time, but actually did that very successfully. I wrote a book for families based on our experiences in this project called Out of the Darkened Room, which describes some of the experiences we've had. There are many different stories about that. And I'm very pragmatic. So when we talk about how to have a family meeting, pay attention to the timing of the meeting, gain commitment to the process from the entire family, begin by identifying specific major concerns and addressing them, bring together and reknit the family history, plan to talk more than once, and draw on all the available resources to get through depression. We describe depression on the analogy of rheumatoid arthritis, medical illness. There are going to be times of good functioning, times of difficulty. You need to be involved with a caregiver over time. And as Mary Jane mentioned, this has been used in a number of countries. It's been used as the basis for a big program in the military called FOCUS, which deals with families facing multiple deployments. And it is an example of the kind of family-based preventions that we think probably have considerable merit. I would say that in keeping with my emphasis on the long-term theme, we were able to follow in an NIMH trial many of these families for 10 years, all of them for at least 4.5 years. We got good results. We got high rankings in the National Registry of Effective Programs. But what was really striking was that the understanding of depression evolved over time. It changed. So what we were trying to do was create the possibility of a dynamic, interactive conversation about adversity and how to overcome it, not coming to a single static understanding. What works for a child at 12 will not work for that child at 16. So as we think about health literacy and working with families, we need to think about how they can develop the problem-solving, effective strategies that will help them through. I worked with Jesse. This is about understanding depression across development. He had the tragedy that afflicts, fortunately, not too many children. His mother committed suicide from a manic episode while she was hospitalized. He was brought to me at 7. He was very angry, very controlled. And of course, I think the thing that I did for Jesse that was most important was not diagnose him with bipolar illness, but rather sit with him and talk to him. And it was very interesting. He was able to say, I can put inside myself the good parts of my mother, and the other were the illness, but he didn't want to know anything about the illness until he was in his teens. And I think that speaks to how these are developmental processes. He eventually went on to be an extraordinary young man and someone that I admire to this day. So another piece of this work has been, can you give me the next slide? Another piece of this work is working with people in different cultures. Finland has a long tradition of instituting evidence-based practices. They did the first community-wide evidence-based intervention for diet and exercise, the Karelia Project, which went on to be a model used all throughout Europe. My colleague Tuti Salanthaus, who's the shortest, probably the tallest in terms of her reach and vision, but the shortest of the people in this picture, had the idea that they needed a countrywide program such that in every health center and in every mental health center, they routinely asked people who were parents about their children. and offered them services. And she asked me to help. This is her program. She's done an extraordinary job. But it's an example of how over 10 years she achieved that, trained thousands of people. And I think about it as I think about Colorado and how you stepwise want to roll out something that can be large. So she got support from the Central Health Ministry, support from the Finnish Academy of Sciences, public health campaigns for leaders and administrators, general public health campaigns, recognition from the beginning for a need of a multi-year effort. She anchored this in the UN Convention on the Rights of the Child, and there was a law in Finland, there's now a law in most of the Scandinavian countries that say that children who have mentally ill parents are entitled to services if they need them. They had no services. So she leveraged that law to develop services. And I, of course, had been very involved in the development of Family Talk and thought that was a great intervention. She used that. But the most important thing is she developed a whole bunch of other interventions as well. One size doesn't fit all. You get at the same principles. What she did was to write a book for families and then develop a very brief intervention. Let's talk about it. And most of the people she trained were primary care people, primary care docs, because that's where most of the care for mentally ill people in Finland is. So this is the beginning of the book. You can see people in their different corners, and this is beautifully illustrated. The practitioner gives the book to the parent, has a series of conversations with the parent in one session. The parent reads the book, comes back, and talks about it in the next session. This is just the super child who's taking care of everything for the mother. And as the work goes on, the child is able to be a child again. The mother is able to take on the responsibilities. And she had a family of interventions. Let's talk about it is when I just said they used Family Talk. They used parent and child groups. She put into the healthcare system, she worked for the health ministry, a child consultative meeting. Anyone, parent, teacher, health practitioner, could call a meeting to get everyone who was working with the child together in one room to talk about what would help the child. The parent was there, sometimes the child was there. Again, very much on the primary care model of let's get everybody together and talk about it. And then they applied this approach to medical illness, substance abuse, incarceration, foster care, and a whole series of other things. Again, successful strategies, ongoing involvement as key stakeholders. She said that this worked because there was a large unmet need. People had been worried for decades about people with mental illness trying to raise children and not knowing what to do. This gave them some simple practical strategies. The interventions were able to be widely used. Flexibility in the adaptation, recognition that training takes place in a larger context with larger goals, a decision to train the trainers, and a collaborative multi-year effort. But perhaps most importantly, her view was that we needed to change the paradigm in child mental health. A paradigm which spends a huge amount of money on very few kids and doesn't get very good results. She wanted to use the development of interventions to move from models of psychopathology to models of development and resilience, from a curative orientation to a health promotion and preventive orientation, from a clinician-based to a parent-family-based family work, from parental incompetence to parental competence, from questions and answers to narratives, and from adult to child-focused work. Obviously, many of us in this country are trying to bring about some changes in child mental health that reflect these principles, and I think using the drivers of integrated care in the ACA are likely. But the final take-home is that I think we can also use our practices to try to look at how we can look at the larger issues we must address. Certainly one of them is the widening gap between rich and poor. It's an increase in health disparities and wealth disparities that we're facing. I think the integration of primary care and mental health, and more generally mental health prevention, offers one way of narrowing health disparities. I also think people get very pessimistic about poverty and say we can't do anything about poverty. But you know, there's a very interesting editorial by Kathy Eden and a colleague in the New York Times on Sunday. I know her, and I actually was at an Institute of Medicine meeting. I'm on another committee on supporting the parents of young children, and Kathy spoke last week. And the editorial was about the importance of the Earned Income Tax Credit and how that's a poverty program that's working very well because it rewards people who are working, and they don't look on it as getting welfare. They look on it. And I think there are some things we can do about poverty. We need to. As far as the challenges of a truly diverse, multicultural society, I've argued that we do all these adaptations in different cultures, but the real truth is that when we actually adapt something well in a different culture, it transforms the intervention. We learn a great deal about ourselves, we learn about the other culture, and that's what we should be thinking about. And finally, you walk down the street in Finland and you see children that are well cared for. If you look at the outcome statistics, they have much lower rates of teen pregnancy, much better educational outcomes, much better health outcomes, much better juvenile justice outcomes, and it is because they have invested a great deal in the first 10 years of life and in the social systems that underlie. There's an Institute of Edison report fairly recently that suggested we have to spend so many dollars in healthcare because we don't spend the dollars on social programs early in life. And finally, I'll end with a personal story. So we have a daughter who in the new age in Colorado or Boston, we would say, this is a young woman in a committed relationship with a life partner. In the old days, we'd say she's married. Both are true. And she's pregnant with what, if all goes well, will be our first grandchild. Okay, so I obviously am thinking about these issues, but she works at a good local hospital, Mass Eye and Ear, and they have no maternity leave, none. And so what Anna will do is save up very carefully all of her vacation time and all of her sick time and eke out, some time. And her husband's parents and we live in the Boston area, so she'll have grandparents to support her and so on and so forth. But I think we have to have family leave policies. It's nuts not to, and that's only one part of this safety net. And then to go back to what I said about implementation dissemination, I asked myself the question, okay, if we're really trying to take care of everyone in the population, just think about this, that many women who are of childbearing age in low-income jobs are not allowed to accumulate vacation time or sick time, so they can't use that option. Also, many women working in low-paying jobs, what's the key thing about childcare? It's predictability. I'm going to work these hours and these days. I'm going to use daycare. I'm going to use my children's grandparents. I'm going to use people coming into the home, but I'm going to cover these hours. Okay. But many people working in low-income jobs don't have predictable hours. They work nights, they work weekends. So we need to think about family leave that really works for our most vulnerable citizens as well. So we can use our healthcare interventions as windows into our society, windows into how we're doing, and think about how to make things much better. Go big. Thank you.
First question.
Okay.
I don't know if this is on. No?
Is this one on?
Thank you, sir. What happened? What changed 20, 25 years ago when you went from being an excellent researcher, excellent clinician, to becoming this advocate and this spokesperson for children and families?
Well, it's hard to talk about. Changes that you go through sometimes occur gradually, but I think what happened to me was, I'll give you one example way back and then something recently. So one of my mentors was Julie Richmond. He was the first medical director of Head Start. He was Jimmy Carter's Surgeon General. And Julie said that when they started Head Start in 1965, it wouldn't have worked without the extraordinary commitment of the federal civil service, Jules Sugarman and various other people. In other words, I spent a lot of time developing interventions. I was an academic child psychiatrist, did the kind of things that academic child psychiatrists do, but I began to get much more interested in how we change things in people's lives. And that led me to policies and to advocacy. I think the other side of it is that if you listen to the stories of the advocates, they are so completely compelling that you can't turn away. So I've been You know, I've been on the board of Mental Health America. I work with you at the Carter Center. I'm on the board of Families for Depression Awareness. I'm helping my friend Sergio Glaxiola Aguilar with NAMI California. And as you listen to these stories, much as the stories today, they're compelling, and they say, it's not enough to provide the academic evidence. We need to see these systems change. I think the other side of it is, as in the room today, it's a wonderful community to be part of.
Great answer. Yes.
Is this on? Yep. So I was trying to figure out if I should ask you a question or if I should make a statement, and I decided, well, if I ask you a question, I'll put you on the spot. So I thought I'd give you a little bit of room here. You know, we have this wonderful thing in the state of Colorado. It's the school-based health program. And it really is enormous, pervasive around the state. And my wife is one of those providers. She's a nurse practitioner. And we have very civil debates, I guess it depends on how we define civil, about what the school-based health program should be. And after listening to you, I think I'm a little bit stronger in the idea that our fantasy through that is to be able to give a kid enough skills by the time they're 18 that they are healthy, whatever that may mean. And the things that we do well in primary care are taking care of colds or asthma or whatever. The things that we do very poorly is giving them those skills, working with families. Well, the school-based health programs have this amazing, wonderful thing. They're with them all the time. And I wonder if the mission of the school-based health program should be different in the sense that that's their mission. Identify these kids at risk, give them or their families the skills to be healthy.
So I think it's a great question, and I would say in the IOM report we have a great deal of evidence about the effectiveness of school-based interventions. Mark Greenberg and a group at Penn State has done an exemplar program. Much of the substance abuse prevention work is in schools. So I absolutely agree. I would just say two things. I think the mission of health promotion and prevention is one that schools should embrace. I think the relationship that schools have to families in deep distress is very complicated. And I founded a program at the Children's Hospital Neighborhood Partnership that tries to put really high quality practitioners in schools. And it's now, independently supported by philanthropy. I was chairman when I founded it. I'm chairman emeritus now. And I think it's a terrific program. But I think it's been difficult. Schools, in my experience, they're just not very interested in families that are divorcing or families that are abusing substances or other things because they have a different mission. And so I think we have to think about the way to bring families in with dignity and with respect. And I think we can do that, but it's not as straightforward as intervening with the kids. The one thing I would clarify is I think there's some very good universal preventions that we can use in schools, not just for kids at risk, but for the whole group that work pretty well. Great question.
Hi, my name is Jan Jenkins. I work at a primary care and integrated health center for refugees, newly arriving refugees, and we have been doing screening of all newly arriving refugee adults, but we're getting ready to branch into screening of children as well. And we're starting with the primary care doctors asking the parents about if they have kids that they're concerned about, and then we're going to bring them in for a screening and then provide mental health services for them. I wonder if you have any advice for us in starting out.
Well, I think I've got one general comment and then one specific. The general comment is that the National Child Traumatic Stress Network has a lot of interest in this. And actually in Boston, we have a refugee mental health trauma grant. Yeah. So I think it's a really important issue. I've been involved with people who adapted the family talk intervention for use in Rwanda, where there's a great deal of trauma because of the genocide and other things. And we're now trying to adapt it with Bhutanese and Somali Bantu refugees Boston. I think the issues that are so important is it takes a really long time to be trusted. And it takes a really long time to be trusted to ask the questions about trauma, which may involve the family. And so you want to have cultural brokers and as strong an alliance as possible in doing screening and in opening these things up. That said, all the data would suggest that these refugee populations are at very high risk and certainly are in need of services.
Hi, thanks for being here. Thanks, Colorado Health Foundation, too, for putting this together. It's really amazing. My name's Kim Easton. I run Urban Peak. We provide services in Denver for youth who are experiencing homelessness or at risk of becoming homeless. My question for you is whether you have any examples or models of programs that support transition-age youth who are disconnected from their families, disconnected from any kind of, probably have never had medical care in their lives, dental care, certainly not behavioral health care. Any examples or advice on how to create an integrated healthcare model to support these young people who have never had a trusting relationship, who developmentally, due to the trauma that they have experienced, are not an adult decision maker. They're really still a young person decision maker. And how do we build a system that's supportive, that's clinically sound and developmentally appropriate to meet the needs of these young people?
Yeah, well, it's not a question I'm going to answer in 2 sentences, but it's a crucially important question. And the fact that people have not been able to do that, I think, speaks to the importance of the problem. I think that one thing is we need some stability of caregivers for these youth. Another is we need to think about the range of services, so housing, food, employment, along with health. And we need to think about where the strengths and resiliences of these young people are. I did a lot of work with the Better Homes Foundation and Ellen Bassick, who's a child psychiatrist who's been particularly concerned about homeless youth, and we, with John Buckner, we did a lot of studies of resilient homeless youth, and we found that the single thing that made the biggest difference was some capacity to be self-aware and to self-regulate. And so I would be thinking about how to foster those in the homeless situation. Ellen and I recently had a paper in orthopsychiatry arguing that we need to reframe what goes on in homeless shelters to pay much more attention to parenting and the care of, and there are lots of children in homeless shelters, and most of the care is not organized that way. So I think that's another piece. Do you want to comment?
Yeah. One of the areas is that these families and these children need psychosocial interventions, not the traditional mental health that we've known before with all the science behind it, but actually begin to look at housing and employment. If you ask these young people what they want a place of their own. They don't want to be in a whole group setting. They would like to also have a job and to have some sense of purpose. And so I think the financing mechanisms are going to allow us to get reimbursed for those kinds of services, along with all the other psychosocial interventions, is critical. And there is a panel currently at the Institute of Medicine where we're looking at how to actually measure and do that particular so that we could have the reimbursement available for you to be able to build those services for those youth.
I was shown a large red stop sign. So I thank you very much. You've been extraordinary. It's an extraordinary day, extraordinary set of questions, and it's a great honor to be here. Thank you.
Thank you.
Thank you, doctors, very much for your time and coming to Denver and spending your knowledge and experience with us. We really appreciate it. The last speaker we wanted to bring up Jeannie Ritter. We want to bring up somebody that everybody would be afraid to say no to, so we knew Jeannie fit that bill. Jeannie has been a Denver Public Schools teacher. She was First Lady of Colorado up through 2011 and is now the Mental Health Ambassador for the Mental Health Center of Denver. And as part of her work, and partly because of her work, Denver, the city of Denver, now has a behavioral health policy office in the mayor's office with Don Morris, and that's policy right in government where we want it for mental health. So,
Thank
Jeannie.
you, Michael.
And you've all been, thank you. Really a great audience today, and I was heartened to hear where folks were from. And so just an amazing opportunity for us to hear stories at this level. And I thought I'd add another story to this. Our boy, Bill and I have 4 really amazing kids, and our third son was a Denver Parks and Rec lifeguard for several years just north of here, and actually 7 years he was at Curtis Park. And we know what it feels like to be a kid getting out for the summer ready to swim, right? We know the benefits of that. But somebody didn't get around to it soon enough, and so I guess there were cracks in the pool, and so the pool was closed when it should have been opening, when these kids are all, anxious about getting into the pool. And day after day went by, and everybody's kind of standing by, and, those big gates that close the pool, these dark gates. Well, some young kid found what was really available to him, a can of spray paint. And I'll edit this, but, Sam went there and he found this giant sign spray painted, open this skanky pool already, okay? So that's what I think has happened here today. Enough already. Dr. Larry Green said that, We know, we have in Colorado what we need. I want to think about what is our collective spray can of spray paint that we can get about the business of doing what was talked about here today, what was demonstrated here today. And so in terms of this collective spray paint, we have, you care. You were here all morning. And I know many of you in the community, I know the commitment you have. That says something. You care. We have the foundations. We have not just generous foundations. In Colorado, we have well-informed foundations that get this, and they have their shoulder right up against this issue, and they're pushing this. We have our own influence on others. Was that skanky thing inappropriate? Everybody's so quiet. But we have our own influence on others, like what's the currency with which we move in this world that we can begin. People were lovely today, right? There's not a reason in the world that doctors like Dr. Scott and Dr. Glenn would have to be the new nuns out there, doing things because they know it's right and not being reimbursed for it. So I think, there is a payer conversation that needs to take place. But the form it takes, the more we can count on people like Debbie to show us the model, distill down, if you can imagine, like she said, on the ground in those practices, and was able to distill it down to just a few slides to really give folks a rubric for how we move forward, what this should look like. We have the SIM. We have Race to the Top. We have amazing things going on. Not only that, because other states are really jealous, but we have the leadership to advance those things. We have the expertise inside our state to really mobilize around those resources and expand and make the most of them. And then back to the policy, right? Somebody, Dr. Beardsley called it, reward, that these physicians should be rewarded for, and it really is. It's like, where's the system? We know, am I right here? We know what it looks like. We know what it takes. Somebody else didn't have the spray paint thing. In a much more professional environment, it was said, it's not my line, I love this line. We are not one pilot away from a miracle here. Right? We know what it looks like and what it takes. And we have real conviction, I think, in our communities across the state, rural communities with really limited resources. I don't want to mention Texas, but a pox on anybody who is going to prohibit technology from moving healthcare forward. if we don't really embrace and capture this. So I just, Michael, you were like silk today. I just think you did a great job. I want to thank the Colorado Health Foundation for hosting such a robust conversation, for letting us do the work, letting us get in front of folks, and then I just commission you. It's messy. It isn't perfect. It's frustrating. We had some really brave people up here on the stage telling you what it looks like, and I just champion you, and I want to hear more stories from folks that are out there. Thank you again for the opportunity.
Thank you, Jeannie. We're going to let everybody go. Thanks for spending all your time with us today. Thanks to the foundation and to ACT for putting this great event on. Thanks to the streaming audience for tuning in and watching what's been going on here. You're going to be all getting an email with a survey. Like I said, we're all about measurement and evaluation, so please fill out the survey in the email. But the bonus in the email is you're going to get a link to the slides that were here from all the presenters, so you don't have to go searching for them. They'll be right in your email box. So thanks again, everybody, and have a great day.